Good afternoon. Senate Finance Committee is in session, and I'm going to do a quick rundown of the order of the bills that we have for this afternoon. The first one will be Senator Eckhart, Senate Bill 795. Senator Lamb, Senate Bill 830. Senator Hester, Senate Bill 857. Senator Hayes, 784. Senator Kramer, 837. Senator Klossmeyer, 884. Senator Benson, 907. And finally, Senator Reedy, 920. Sponsors will have as much time as they need to explain the parameters of their legislation. And where they have identified a major proponent, that person will have 5 minutes. All other witnesses will have 2.5 minutes. We're going to start now with Senator Eckhart for Senate Bill 795, Oversight Committee on Quality Care, Nursing Homes, and Assisted Living Facilities.
Thank you very much, Madam Chair and Vice Chair and members of the Finance Committee. I appreciate the opportunity to come before you today. This may involve a little bit of your attention, if you don't mind, because I'm looking to you all for some assistance. Senate Bill 795 is simply a couple of tweaks, if you will, to the current outlined in the code membership and mission for this Oversight Committee on Quality Care in Nursing Homes and Assisted Living Facilities. This was created by the General Assembly in 2000, and the committee has been charged with evaluating progress and improving the quality of nursing home and assisted living facility care statewide. The membership is outlined in the bill, and it consists of, I think it's probably 7 to 11 representatives from the executive branch of government. It has 5 to 7 members of the industry, and I believe it has like 7 to 11 members who would be advocates or folks advocating for changes or improvement within the industry. What we did is I looked through the bill and looked through the composition. It occurred to me that it looked like it needed to be a little more balanced because, as you know, on any of these oversight committees or commissions, not everybody shows up to play and participate. So that's one piece of the puzzle. And of course, this was a challenging year with COVID because our facilities were really hit the hardest. And with the shutdown and with the lack of PPE and the lack of staffing, it kind of made a situation that was of concern even worse. So the group actually came together. The leadership, as prescribed heretofore, has been the Department of Aging will chair, the Secretary of the Department of Aging will chair the committee. And she did, and we set up pretty substantial meetings to just look at what was going on and make some recommendations. The committee was very ambitious in its work, and they actually, I think, set out on almost like a strategic planning initiative to have some broad-based recommendations. Of course, as you know, with any advocacy group that's strictly advocacy, you kind of, I guess, bump shoulders or can collide with maybe some of the missions of the executive branch of government. And I think that's where there was a little bit of a challenge moving forward. Because so much of that work, from my perspective, and being on a lot of boards and commission, was significant, it occurred to me that maybe this oversight committee ought to be transformed into something else, but that would become a part of a real focus of discussion within the committee itself. And we didn't have that opportunity because of COVID and because of, getting back to session. and some of the constraints caused, I think, by COVID. So 2 changes I was recommending, and that was to change the leadership. Other commissions and committees have worked well with co-chairs. So there would be co-chairs would be elected from the body, which would then take executive branch of government out of the leadership of it. And then in addition to that, add another one of the industry members so that we had broad representation from the industry, both on the advocacy side and from the industry side, thinking that if we're going to get substantial change moving forward, having all the players at the table might be significant. Unfortunately, in the drafting of the bill, there were some categories that I don't think were fully understood. So I am proposing an amendment that will delete several sections of the bill that outline specific sections of the code, i.e. Members, and that's on page 3, section C2, and then the one next to that, 2.1 and 2.2, to delete that and just say that 2 co-chairs will be elected from the membership, and the membership can figure that out, because if the composition in my mind is balanced, that would give us an opportunity to have broad representation from all aspects and input to continue the very important work that we need to have moving forward with looking at the oversight of the industry and the quality of care. So with those amendments, Madam Chair, I would encourage your favorable consideration of these minor changes for this year and recommend passage of this piece of legislation. Now, I know you're going to hear from some of the members of the group who have a difference of opinion with this, and that's fine. I mean, I think that's why we need to have more discussion of this as we go back into our work during the interim. But these couple of changes I thought might get the ball rolling to launch into that broader discussion, and then maybe come back with some recommendations to you all next year on whether we should become a full-fledged commission that would be in full commission status to be an oversight entity and advocate more completely for the industry as a whole.
Okay, thank you. And I do see written testimony from Lifespan in favor of your idea. We're going down to the unfavorables. Eric Coltomaro from the Alzheimer's Association.
Chair Kelly and Vice Chair Feldman, Eric Coltomiro, Director of Government Affairs for the Alzheimer's Association in Maryland, and here today respectfully in opposition to SB 795 as drafted. The Oversight Committee, as Senator Eckert outlined, is a multi-stakeholder group which looks at the industry, which in the nursing home space has seen an increasing number of mergers and acquisitions. Since the Oversight Committee was first created, real estate investment trusts can now own and operate facilities for Maryland seniors. And among assisted living providers, while the vast majority of providers operate small facilities, the 8% of facilities over 50 beds have the majority of our assisted living resident population. The Oversight Committee convened monthly in the summer of 2020 and issued an annual report with a series of findings, which is the result of multiple subcommittee conversations. Thank you to Senator Eckert and Senator Beidel for being active participants in both the subcommittee and the full committee. The purpose of the Oversight Committee to evaluate progress in improving the quality of nursing home and assisted living facilities statewide is appropriate. The execution of this and its other goals is lacking. The Alzheimer's Association, however, is concerned about this legislation. Overall, the committee is not lacking for members. There are currently 31 different positions, and 83% of them are filled. In addition, the Secretary of Aging is an ideally neutral chair of this committee. Their position in cabinet can help elevate the need to improve this industry and bring stakeholders together. and I do not believe a system of rotating chairs where a for-profit industry representative could conceivably oversee this oversight committee is an effective solution for evaluating the quality of care in this industry. All told, the structure of the committee is not the problem. Again, it is the implementation of the oversight committee. The Alzheimer's Association would be happy to participate in conversations about how to improve this committee with members of Senate Finance and elected officials, representatives on the committee. Solutions could include an annual briefing for elected officials each interim session, a joint meeting each year with the Maryland Medicaid Advisory Committee, and a set schedule of more regular oversight committee meetings overall. In closing, I want to say thank you to Senator Eckert. The district she represents, including some of the best ice cream in the state at the Scottish Highland Creamery in Oxford and the wonderful family-friendly Hyatt Regency on the Cambridge waterfront, are lucky to have her as a senator. Yet I ask for an unfavorable report on this bill, as it's not the right solutions, I believe, to create a more effective oversight committee.
Okay, I think you've been very clear, but you do agree it's a very important committee with a significant job to do. You just don't like this particular, and that the committee isn't working up to standard altogether, but that you need a different solution than the one that you think is proposed in this bill. Is that it?
Yes.
Okay. All right, Senator Kramer.
Thank you for that, Madam Chair. Eric, question for you. It appears that the legislation does two things. One is it adjusts the membership of the body. The other is that it would change the chair of the body. And I noted in your testimony that you said the Secretary of Aging is the ideal neutral chair. My question of you is, what role does the Secretary of the Department of Aging have with regard to the subject matter of nursing homes and assisted living facilities? Does the Department of Aging have anything to do with licensing of nursing homes, assisted living facilities?
Nope, she does not, Senator.
Does the office have anything at all to do with oversight of nursing homes and assisted living facilities?
She does not, but I think, oh, I'm sorry, I don't want to interrupt.
Yeah, go ahead. No, that was it. I was just looking for the answer. It's easy.
Yeah, but I think part of the logic behind naming her as chair, and I would actually defer, if the chair allows, to Tammy, who's been on this committee for many more years than I have, is that in looking for an ideally neutral chair, the Secretary of Aging is ideally the one to take in all the information. And especially because she does not oversee OHCQ, serve as a
Eric,
neutral.
let me ask you this. This is a very important oversight group with a very important charge of very technical issues relating to nursing homes and assisted living facilities. And I guess maybe you're missing my point, is that the Department of Aging has nothing to do with nursing homes or assisted living facilities or any expertise whatsoever with regard to nursing homes and assisted living facilities. So I can understand, and when I saw the bill, I placed a call to the secretary to ask that you do with regard to this, industry. And she said, we don't do anything with them. So I said, well, then why is it that you're somehow the chair? And she goes, it was stuck in statute and we have no expertise in this field at all. So I believe what Senator Eckert is pointing out in her legislation is that this agency is not appropriate to be chairing such an important oversight committee, that where knowledge and understanding and being part of the process is very important. I would also ask you this, are you aware of, and I'd be curious to know, are you aware of any other entity similar to this oversight group that is chaired by a member of the governor's cabinet.
So there are a few different points to respond to there, Senator. One, I would say intentionally, again, the Secretary of Aging was named as the chair of this committee because she does not oversee OHCQ. And for a committee where OHCQ reports to them, for a committee where OHCQ is involved, it's important to have that independence so that the chair is not the one looking at what their agency does. Two, to your point where they have nothing to do, if I heard your words correctly, and please correct me if I'm misquoting you, I would say, honestly, that's kind of a shame. In the long-term care space, the Secretary of Aging, yes, she doesn't oversee OHCQ. She may not have the subject matter content of Acting Secretary Schrader or the team at the agency, but she has a heck of a lot to do. And we could issue reports and address social isolation at long-term care facilities. She could collaborate.
And Eric, thank you. I'm not asking you to speculate on what you think could be done. We have very defined offices here and very defined responsibilities within those offices, and all of the governance for these nursing homes and assisted living facilities is in the Department of Health. So I appreciate you're asserting what you think are all the things that maybe would be inspirational, but I'm looking at the facts of what our government and how it is organized has in place the responsibilities for these. So I appreciate your addressing my questions, and thank you, Madam Chair.
And Madam Chair, if I may, just one last point. And Senator Kramer, I think we may have to agree to disagree on this, but I would just add that I hear what you're saying, but this bill at its core, and this committee at its core, is about helping seniors. And that's
nobody's questioning that, Eric. Thank you. I appreciate your advocacy. Nobody's questioning that at all. And I can assure you, no one in this state legislature has done more on behalf of our seniors than I have and my colleagues on this committee. So thank you.
Great.
I would just butt in myself and say, I can see both points of view and the importance of having a chair who has no dog in the fight in a way. But to be honest, I like what Eric is also saying. Maybe we ought to give more responsibility to the Secretary of Aging because her entire constituency, although they basically are in continuing care communities, they are aging. And if some of them lose too much in the stock market, they have to maybe move out of the continuing care and go be helped by people who are dealing with persons who are aged in other circumstances. So I think all of us care about this population, and we should. Okay, let's
Madam
go
Chair,
now.
Madam
Yes.
Chair, could I just make, for the record, we have the greatest Secretary of Aging of any state in the nation, Secretary Rona Kramer. I just want to make that statement for the record because, you know, I just want to say that.
She is
Okay.
wise. She is very wise.
Maybe that's why Senator Eckhart wanted to put that wise and not biased person in as chair. But okay, Tammy Bresnan is next, and you represent AARP.
Good afternoon, Madam Chair and members of the Senate Finance Committee. I am Tammy Bresnan, and I'm the Advocacy Director for AARP. Just a minute of personal privilege. Virginia Crespo, who testifies mostly on behalf of USM, has fallen and broken her wrist, and she's at University of Maryland, Greater Baltimore, Washington Hospital. She had surgery last night. She intended to present testimony on behalf of USM as she's been a member of this oversight committee for over 15 years representing USM. She just wanted to express the desire to make some particular recommendations to the legislature because we gave recommendations that were not fulfilled. And we think that we could, with a more vitalized committee, subcommittee, do well. We are opposed to adding another member of the industry. We welcome more oversight, but not by the industry. It repeatedly failed to adequately protect our vulnerable citizens. I know that they are an important part of our long-term care spectrum, while families of patients, they have undergone death, destruction of their families, of their friends, and of their loved ones. We want to make sure that the panel's chairmanship is the Secretary of Aging. Almost half of all people who live in long-term care settings are 85 years or older. Relatively few residents are younger than 65, and most are women, about 72%, many of whom do not have a spouse and who are widowed or divorced. I would also like to bring to the committee's attention that the Department of Aging houses the Ombudsman program that is the liaison between long-term care, assisted living, and nursing homes. And so it is a very important part of the Secretary of Aging's function, because these people represent a majority of her population. They represent, people that the Ombudsman works with. And I would beg to disagree with you, Senator Kramer. You have been a very big advocate for our senior population, but I do believe that this function should be housed in the Department of Aging. With that, we'd like to ask for an unfavorable report. We would like to thank Senator Bidel and most of all, Senator Eckhart for her diligence. What we found during the interim trying to work with the industry is that we were trying to put forward issues, and at all times it was met with, Bill Ferguson's on my phone, so that's a little bit hard to, I'm sorry, I'm just a little bit preoccupied, but it was met with, we just want to be stabilized. And what we don't know is, and what we would like to know is, what have they done with the money that came from the federal government? What have they done with? And I think those are all things, because we had so many Marylanders, almost 40% die. So I'll leave it at that. I know that you will do what's in the best interest of our older population. You always have. We respect your opinion. And with that, I thank you for just listening to me for a few minutes.
Thank you. Are there any questions, Senator Bidel?
Thank you, Madam Chair. And Tammy, thank you for your testimony. And you were just a great deal of help serving on the Oversight Committee. And it was my first year, so learned a lot. Would you be comfortable if the Ombudsman was the chair? I mean, they're really the go-between, as you said. Would that be an acceptable change, you think?
I don't know what her workload is. I mean, I think Stefan is a wonderful advocate. I don't know if the industry would think that she was unbiased. I don't know. I mean, she's supposed to be unbiased and listen to both sides. So it's an option that we would consider.
Okay, thank you very much, Tammy.
Okay, and we're going next to Claudia Balogun from 1199 SEIU. Did you get unmuted?
I am now unmuted. Apologies. Thank you, Chair Kelly and Vice Chair Feldman and members of the committee. My name is Claudia Balogun. I'm a researcher with 1199 SEIU, and we are also respectfully submitting testimony in opposition to SB 795. This Oversight Committee on Quality Care in Nursing Homes and Assisted Living Facilities is an important tool to give consumers and advocates a voice in the oversight of these long-term care settings. And yes, the need for industry oversight has only been magnified by the pandemic. Our members and the residents who depend on them need a committee that's dedicated to advancing difficult conversations about improving quality standards. So in our view, the structure of the committee is not the problem. We're also opposed to adding another industry seat to the committee. So we agree that the Secretary of Aging is an ideal neutral chair. We believe their cabinet position can elevate the recommendations we make. And I want to talk a bit about our participation, 1199's participation on the subcommittee that's been referenced that met throughout the summer. I just want to note how impressive these conversations were. They were refreshingly honest. They displayed a deep commitment to improving quality, and we're really thankful for the participation of both Senators Eckhart and Beidel in those meetings. I want to talk about how we tackled COVID-related concerns like PPE and testing, but we also tackled workforce recruitment and retention challenges and short staffing. We talked about quality of life concerns, transparency of data, and even provider reimbursement challenges. To Senator Kramer's important questions, I want to note that the work we covered crossed across many agencies of different technical expertise, not just OHCQ. Workforce concerns are covered under Department of Labor, financing by Medicaid. There are just so many technical areas that come together that are required to improve quality in the industry. It's our view that the recommendations we developed just weren't accompanied with sufficient briefings for Maryland's elected leaders. And given the press spotlight on long-term care facilities, this was a missed opportunity. I also just want to note 1199 operates in states like Massachusetts and New Jersey, and oversight bodies in those states, and I believe New Jersey was at the cabinet level, I have to check, they managed to promulgate recommendations for meaningful changes to improve quality. So what we would love to see is participating in a conversation about ways that improve this committee that don't make changes to its governance structure. And we also appreciate the work of Senator Eckhart to raise this issue. Thank you.
Very important issue. All right. Well, that ends the testimony on this very important bill. Let me just say I've done a lot of work where seniors are concerned, and I have concerns about the current output and any impediments to progress given the current arrangement, and don't know what the answer is. So I appreciate the various views we have gotten today. I think everybody's thinking strongly, including Senator Kramer. We just really need to think about all of the possibilities that are there, and we must do better. We definitely must do better. And it may partially be even the way we have cabinet positions subdivided in Maryland that cut across various ways of looking at the lifespan, the health, the welfare, and the impediments to health for this same population that we're talking about. And it certainly matters if they're in assisted living in Maryland, where we have almost no infrastructure at all and no real regulatory oversight. And many of the seniors there are have less in terms of economic resources and or in many cases, family or close relatives to assist them. And many of them are being, well, I won't say more, but we've got all kinds of problems and needs. And all of our seniors deserve to be as well served as they possibly can be. So I think we need to look. If you don't like Senator Eckhart's recommendation, we all need to at least go into the interim pledge, maybe to put together a work group to do some thinking about what would be a way of our doing better. Okay, thank you. Senator Benson, just unmute yourself. Unmute, yeah.
Thank you very much. And I also want to thank Senator Eckhart for bringing this to our attention. But I must tell you all that this is the care of our people in nursing homes is a serious problem. I want to tell you, I just had to endure this with my sister. And there were some serious concerns about where she was. The question I want to ask you is, what authority, someone needs to answer this question for me. What authority do the local Department of Aging, the local departments of aging have on these nursing homes, the quality of care? when I called the Department of Aging or Family Services in Prince George's County, they told me that they had no authority over what happens, the regulating of what happens or handling concerns in a nursing home. Who is responsible for that?
That's a bit off from what they came prepared to discuss today, but you're asking the right question. So anybody listening who's been on this committee dealing with the nursing home situation, or any member of the General Assembly who knows something about it or who works with the elderly, get back to Senator Benson.
Okay, Madam Chair, real quickly.
Yes.
The Office of Quality in the Health Department, the Office of
Healthcare quality.
Yeah, they have, and nursing homes are highly regulated. So they are the folks that are inspecting and going in on a regular basis. But you know,
It's in the Health Department as opposed to the Department of Aging?
The healthcare quality division within the department.
right,
They're the regulators.
right.
Okay,
That's crazy.
thank you.
Thank
Okay, that means we got a lot of work to do. When we go
Yep.
away, we all feel like we really haven't solved the problem. We know we got to keep.
Right.
Okay, Senator
Thank
Lamb
you.
is here for, thank you, for Senate Bill 830. Senator, you have as much time as you need to lay out the parameters of your bill. Your lead person has 5 minutes, and then all of your other witnesses will have 2.5 minutes each. So you're on now.
Great, thank you, Madam Chair. Happy to be here and to speak on behalf of Senate Bill 830. For the record, Clarence Lamb, Senator in District 12, and esteemed members of the committee. Senate Bill 830 seeks to improve access to healthcare and improve educational outcomes for Maryland students. It's been shown time and time again that students dealing with health issues often will have worse educational outcomes. This is especially true for low-income students who don't have access to healthcare services. These students are more likely to miss school due to illness or have a harder time in class due to stress from dealing with chronic health issues. To help address these issues, 13 counties have created school-based health centers in 86 different schools. These school-based health centers are health clinics located in schools that can provide primary care, behavioral health services, and some also provide dental care as well. Although they often coordinate with school nurses, school-based health centers are technically separate from school nurses and provide a large suite of services. I should also mention that, I think through leadership in this committee and others in the General Assembly, there is a council on the advancement of school-based health centers that was established by the General Assembly many years ago. And I am the Senate representative, along with Delegate Collison, to that council. And so they've been doing a lot of great work. This bill also stems from some of the discussions that the council has had as well. It seeks to build on the state's progress by ensuring that school-based health centers and local school systems have clear and clinically appropriate guidance. Currently, the statute doesn't task any specific department with the responsibility of making guidelines for school-based health centers, leaving health centers and local superintendents to navigate a complex myriad or absence of guidance between MSDE and MDH, Maryland Department of Health, in order to help gain answers to some simple questions. Additionally, there have been several examples where school-based health centers are given guidance that doesn't make clinical sense. A few examples, local health systems were told that they couldn't work with local hospitals to create new school-based health centers, and this committee had to pass legislation to make clear that there wasn't a prohibition on school systems working with their local hospitals to provide health services to their students. And also, just 2 years ago in 2019, I had to sponsor legislation to require MSDE and MDH to allow nurse practitioners to direct and lead school-based health centers, although Maryland law was already very clear that nurse practitioners' scope of practice already permitted this work to occur. With the lack of clear departmental guidance, the proliferation of school-based health centers has languished in many ways, have had to repeatedly turn to the General Assembly to help simple questions through legislation. Because of concerns raised by school-based health centers and local school systems, we thought it was appropriate now that the statute clearly did delegate the responsibility of supporting school-based health centers. This bill tasked the Maryland Department of Health with developing guidelines for school-based health centers in consultation with MSDE and other relevant stakeholders, and begins the process of moving the primary responsibility for school-based health centers to the Bureau of Maternal and Child Health within MDH. Because of their expertise in child health, we believe that the Bureau of Maternal and Child Health is best positioned to develop clinically appropriate guidelines to support the mission of school-based health centers and improve the health and educational outcomes of Maryland children. I know that MDH and MSDE have expressed concerns that this bill in particular about whether it specifically impacts MSDE's ability to oversee school-based health centers. So while drafting this bill, we work with the Attorney General's office to ensure that it does not do anything that reduces MSDE's ability to oversee schools or school-based health centers. This bill only requires MDH to create guidelines for school-based health centers and to oversee the grants for these centers. During the House subcommittee meeting, MDH did not express any concern about the department having this responsibility as part of their role, and MSD did not attend. It's also important to mention that this bill has the support of educators, the MSDA, the Nurses Association, and pediatricians and other allies as well. I know that there was some written testimony submitted from Maryland Right to Life. In reading through their letter, I believe their concerns are a little bit off base, and I believe they're based on some factual inaccuracies with regards to the bill itself. So this bill is only about ensuring that our local school systems have the timely, consistent, and clinically accurate support that they need to help provide for student well-being, as well as primary behavioral health care and dental care to students who need it. So it's a fairly straightforward bill as you glance over it. Happy to turn it over to other members of the panel. And I think we have Robin Elliott and shimoya Gardner.
Okay, Robin Elliott is coming up next, representing the Assembly on School-Based Health Care. You have 5 minutes.
Thank you, Chair Kelly, and to Senator Benson, happy birthday. Very exciting. So thank you so much, Robin Elliott, here today on behalf of the Maryland Assembly on School-Based Healthcare, very enthusiastically in support of this legislation. This is at core a public health measure. School-based health centers are currently housed at MSDE, and as Senator Lamb explained, they're caught a little bit between the two agencies. They are community health centers, just like ones that may be down our street. They're just within the walls of a school. So in looking at all the issues that they're facing, we very much support the idea of integrating them into the Maryland Department of Health. This is a public health measure. It'll help ensure they're part of the public health infrastructure. That includes vaccinations, that includes integrating with the WIC program, or getting fluoride varnishes for children. As Senator Lamb said, it would be a move of funding. There is $2.5 million that has been in MSD. It's been level funded for a number of years. That would be moved over in 2 years from now. The department has to come back with a plan to do that. And in the future, we're really hopeful that school-based health centers can grow. As Senator Lamb said, they're in 13 jurisdictions. That means 11 jurisdictions have no school-based health centers. And we really want to look at a health approach, a public health approach to assessing where school-based health centers should be and supporting local communities in building their own school-based health centers to meet the needs of their students and those students' families. Thank you so much.
Let me just ask you a question, Robin. You mentioned inoculations which kids can get at school-based health clinics, and many, maybe if the parents don't really have health insurance or they're out of work or something, don't have another means of doing that. Are there other sort of school-related circumstances that might cause a child to need the use of a school-based health center? If there's an accident in a school, if you're in a school where there's a center as opposed to one where there's not, and there's an injury or something, is that another basis on which we would want to promote having them?
Yeah, thank you for the question, Senator Kelly. So every school has a school nurse. I think we all probably remember being in the nurse's office at some time or another, and they are the ones who administer first aid. School-based health centers really are meant to provide more primary care services. And so they're really designed to help children stay in school and learn. And so they treat children with chronic diseases such as asthma, hypertension. They do prevention around diet issues. Really importantly, especially right now, is they deliver behavioral health services. And then and a few school-based health centers also offer basic dental care. So all these services together, most of them go to children who are on Medicaid or who have no insurance. They really help ensure that that child and the family can maintain that child's educational learning and participation in school.
Okay, are there other questions for this witness? Okay, we're going next to Shimoya Gardner.
Thank you, Chair Kelly. For the record, my name is Shimoya Gardner. I'm here representing the Maryland Alliance for Racial Equity in Education. Good afternoon, Chair Kelly, Vice Chair Feldman, and members of the Senate Finance Committee. Marie is in support of Senate Bill 830. Marie is a coalition of education advocacy, civil rights, and community-based organizations committed to eliminating racial disparities in Maryland's education system. I will cite a personal anecdote. I have firsthand seen a school utilize a fully operational school-based health center to immunize and conduct a physical required for enrollment for a new student who was both uninsured and from a family that was undocumented. These services were required for his physical attention in class, and due to the collaboration, innovation of the school-based health center staff, they were able to eliminate what could have been potential weeks or months of missed class time for this student. So if we allow school-based health centers the environments they need to thrive, we could really transform public education in this state. We've seen it many times during the ongoing pandemic and for generations prior to this, MSDE's poor performance on the educational welfare of Black, Brown, and Indigenous students, especially those also experiencing poverty. School-based health centers, despite their ability to transform outcomes for these groups, have not received the intentional investment and expansion under MSDE that would allow them to thrive and mitigate those disparities in outcomes. Marie also recognizes the threat that is always present for students of color being served by public institutions with histories and presence of betraying our communities. Our support of SB 830 is embedded with the expectation that the staff of the Maryland Department of Health will engage in deliberative processes with impacted stakeholders, particularly the Black, Brown, and Indigenous students, families, and school community members necessary to advance anti-racist policies and practices in service delivery, staffing, recruitment and retention, and cultural competence in decision-making and the assessment of equitable outcomes. For all of these reasons and with that intent, Marie urges a favorable report on this bill.
Thank you. We're going, are there any questions of this witness? Good testimony. We're going next to Tina Dove of the Maryland State Education Association.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. Thank you so much for having me here in finance. It's a pleasure to be here. As was stated, my name is Tina Dove. I'm with the Maryland State Education Association. By way of explanation, because I don't get the opportunity to testify in finance very often, I am an educator. I am a high school social studies teacher by training. I'm currently not in the classroom because I am at MSCA serving my colleagues. One thing I know as a trained educator is that we have to handle Maslow's hierarchy of needs before we can launch our children on Bloom's taxonomy of learning. Meaning if we don't handle their basic needs for food, for safety, for health, etc., we can't get them to learn the things we need them to know. And so I appreciate Dr. Senator Lamb, for understanding the important need for this public health issue to be addressed. And I know that your colleagues on this committee, Senator Benson and Senator Eckert, understand as educator and health practitioner, the importance of making sure our children have their health needs met. According to the Children's Health Report Card that was published out of Georgetown, in 2019, about 48,000 of our children in this state were uninsured, and the bulk majority of those children were children of color and children who were poor. Most school-based health centers provide the primary medical attention or primary medical touch place for many of our students. We have a lot of our students in our state who are Medicaid eligible, and some of them are covered by S-CHIP, but eligibility doesn't necessarily equate to access. So if we can create opportunities in the school setting where our babies are showing up every day for them to get basic medical needs met, both physical health needs and behavioral mental health needs, that is the best way to keep the kids in school where I can then teach them. If they're out of school because they're sick, they can't learn anything I teach them, no matter how good my lesson plan is. So it's super important to support efforts to provide basic medical and dental health services for our children in the place where they are most frequently, and that is in their school building. School-based health clinics, we've seen the effectiveness of them over a number of years in the context of community schools. Many community schools, as that program has been implemented over the last several decades, have found when they've done their needs assessment that one of the things that the school and the community surrounding the school needed was access to basic health care. And for community schools that put school-based health clinics into their schools, they saw miraculous improvements in terms of attendance, in terms of academic outcomes for their children, and for stabilization within their community. So any effort to solidify, strengthen our school-based health clinics is an important move to make.
Okay.
It is an unfortunate.
Your testimony is very interesting and informative. We are just running out of time. Let me see if anybody has a question for this witness.
Madam Chair, I don't have a question, but maybe the sponsor or one of the members on the panel could forward this committee list of them. I'm trying to look for the school-based health clinics. Wasn't able to find on the internet, but it'd be helpful to get that information. That's all.
Okay.
I have that and I'll send it to you.
Okay. Are there any other questions? Are you trying to ask a question, Senator Benson? You got to unmute. Okay.
Am I all set?
Yes.
Hi, Ms. Dove. You know, your testimony resonates so well with me as an educator. Could you also send us a copy of the data that you cited relative to the number of children that go hungry? You cited some statistical data relative to the children.
Yes, ma'am. I was citing the 2019 Children's Health Coverage, a Children's Health Report Card out of Georgetown, and I'm happy to send that to you. And I can send
it to the committee.
Well, send it to the committee. We'll see that everybody gets it.
Thank you.
Yes, I'm happy to do that.
Okay, Senator.
And happy birthday, Senator.
Okay. Yes.
Thank you.
Senator Reedy.
Thank you, Madam Chair. And question, I guess, for Ms. Dove, and I am interested, as Senator Hayes asked, for those reports. I'm interested in seeing those as well. When we talk about poor and minority children being uninsured. Why? And I assume when that happens, obviously it means that they're not able to get the kind of primary care, or the concern is that they're not getting the kind of primary care attention early, so we're not catching things until they become acute, which is certainly a big issue. Totally agree. If a child is if obviously a child and is under a certain poverty level, they're eligible for Medicaid now. So what's the disconnect? And how can we, because it seems like it seems like a bill to try to triage some of these issues and do better with figuring out ways to get kids some kind of care in a school environment, but we really would be better if we were getting them connected to make sure they and their caregivers or their parents know that they're Medicaid eligible, and get them connected that way so they could go to a primary care doctor. I mean, so
before I ask either Dr. Lamb, the sponsor, or Mr. Dodd,
yeah, whoever, yeah.
So one thing that occurs to me about it is that if our parents are essential workers, which many of these kids' parents are, they aren't even at home during the hours when medical offices are often open. They are spending, sometimes when our committee last year went to Sparrows Point on a trip to see how that was working. We found out that many people in the communities that these kids come from, right in that metropolitan area, can't work at Sparrows Point because it takes about 2 to 2.5 hours on the bus, on buses, to get there one way, and about 2.5 hours to get, so there's not enough metropolitan mass transit for their parents to even get to a good paying job that's open. So they told us there were people coming with their cars from Delaware, getting the good jobs there. See, you see what we're saying? So if their parents have to work and cannot, and also are dependent totally on an inadequate mass transit system to get anywhere, that's also why I think many aren't getting vaccinated, the parents, the grandparents, and so on, against COVID-19. You don't have a way to get anywhere. I did talk to a person in Senator Washington's district that I used to represent before they did some redistricting, who told me that after spending 6 weeks trying to find out where he could get the vaccination, an elderly gentleman who's had 2 kinds of cancer and is in his 70s, he had to drive, he couldn't afford Uber, to downtown and go to the convention center. He had to walk 3 blocks, which he left him winded, and I had a $29 parking ticket when he went back for his car. So just think of kids whose parents are poor and are essential workers, or are now unemployed, or the little business that their relative or parent tried to open has had to go out of business because the types of businesses that many people who are not well funded have are some of those that we have had to put the most restrictions on, just given the health environment. So it's not at all difficult to really understand why so many of them aren't seeing the doctor.
And to
answer
if I could,
Senator, and thank you for that. As I said in my testimony, there's a very big difference between eligibility and access. So there are a considerable number of children whose families fall within the federal guidelines, but if they can't get to a primary care physician, either because there are transportation or logistical issues, or they don't have a means by which a parent or guardian can get them there, or if there are no primary care providers in their area that are, that receive Medicaid patients, or are pediatricians or pediatric dentists, if just qualifying isn't enough to have access. So this provides a means by which we can ensure that there is access. This is particularly important in areas that are rural areas where you might have, long distances between medical providers and, the communities that live in those areas. So that's one example. And another, and I hate to bring this up because I think it's a memory that the state doesn't want to keep. We had a 12-year-old in this state who lost his life due to an abscess
that he had. He was Medicaid eligible. His family was Medicaid eligible. There was some glitch around their Medicaid and the ability to access. I believe his family was homeless at the time. And for a $50 tooth extraction that a dentist in a school-based health clinic could have found and diagnosed preliminarily to get that child, pointed in the right direction. That baby ended up in an emergency room, had an infection that spread to his brain, and he died. He was.
Well, that was a terrible case, and I'm glad that we've taken action to try to mitigate that issue for the future, and something that I think has been worked on quite a bit. But certainly, we don't want that kind of thing to ever happen. Dr. Lamb, could I just ask? I'm trying to be sure I understand what all the different things surrounding the bill are. So, in these school-based centers, I know they already exist. I mean, what happens as far as parental notification, parental or guardian approval or sign off? What's the process there? And does this bill affect that? What is current law in any way?
That's a very good question. It does not. So right now, parents need to consent yearly for their kids to be able to enroll in school-based health centers. That's supposed to be the case. This bill does not touch on that at all. It's really just helping to provide more guidance to the Maryland Department of Health to issue responses and guidance for how these school-based health centers can be set up, because we view them really as a benefit. I think all of us kind of concede on that. And to what Ms. Dove was saying, it really is not just an insurance or eligibility issue, it's an access issue, right? So if you just imagine these are, community-based clinics, they just happen to be located in schools, so that, many of these students and kids probably have Medicaid or are Medicaid beneficiaries. And so this helps them be able to more easily get access, whether they don't have transportation, or maybe the nearest provider is a long distance away, or they're not able to get to it within business hours, et cetera, just another avenue by which they're able to seek care in a more accessible fashion.
The way this is my last question, Madam Chair. The way it functionally works is a child set an appointment. Obviously, if there's some sort of emergency situation, they go right away. But does a parent and a child work to schedule an appointment, a regular appointment, like you would with a primary care doctor, or how does that work functionally right now?
So I've had the chance to visit some of these school-based health centers. It depends on the clinic itself and the model and the staffing. Sometimes they have, you may actually have a nurse that's staffing the clinic that's actually covering a few different schools. And so it really depends. If they happen to be there, you can probably handle walk-ins. Otherwise, you may need to have some appointments because they may not be there all the time. So it really just depends on the model and the structure of how the school-based health centers in that school system are created.
Okay, I'm learning more about these issues, so thank you.
Thank you. Right, no more questions. Our last witness.
Oh, looks like Senator Augustine has a question.
Yes.
Madam Chair, thank you, Madam Chair. First of all, Senator Reedy, I'd be very happy to talk to you about these. I've got 3 in my district that are already functioning, provide community supports. And I think that that's really what this is about. It's about providing the community supports that came through the blueprint and really just making sure that we have that we're helping our kids to be able to thrive completely. So there's that. And so Senator Lamb, just getting back to this, I think that you're trying to is this bill really about just aligning this to the place where basically, people who have expertise where it really belongs from a healthcare standpoint? Is that really what is at the heart of this legislation that you're putting before us?
Yeah, so if you were to cut to the chase, I think, Senator Augustine, you've hit it right on the head. This is really just to align the primary responsibility of providing guidance to these school-based health centers, to align it up with the Maternal and Child Health Bureau within the Maryland Department of Health. Right now, because of the way the statute is, it's not exactly clear where the primary responsibility lies. And so I think all of us, as we mentioned, and these school-based health centers already exist, they're doing great work. I think we all want to promote them to the extent possible. This just helps facilitate their growth by clarifying the reporting lines and who's actually issuing, serving as the lead for issuing guidance on how these centers can be and can proliferate. So it's really just kind of realigning those lines in the org chart. So it's not doing anything much more than that. It's just providing some facilitation and guidance there.
Thank you, Senator.
Thank you. All right, we're going finally to Laura Bogley from Maryland Right to Life.
Thank you. Good afternoon, Madam Chair and esteemed members of the committee. Thank you for the opportunity to speak with you today. I'm Laura Bogley, Legislative Director for Maryland Right to Life. On behalf of our members across the state, we oppose this bill and respectfully ask that you put students before abortion politics. This bill is part of ongoing legislation supported by the National Abortion Rights Action League to transfer oversight and funding for school-based health centers from the Maryland State Department of Education to the Maryland State Department of Health. This bill will enable the Department of Health to circumvent both state and federal regulatory requirements for school-based health centers. While school-based health centers were once managed by federally qualifying health centers, the General Assembly last year expanded the types of providers who may qualify to run school-based health centers to include clinics like Planned Parenthood. Under the strong influence of the National Abortion Rights Action League, Planned Parenthood, and their Abortion Coalition members, the state has expanded the role of school clinics to include reproductive health services, including filling prescriptions for birth control, implanting long-acting reproductive control devices, providing comprehensive reproductive health, education, and pregnancy options counseling, and providing referrals to additional off-site reproductive health care services, including to Planned Parenthood, all without parental knowledge or consent and at the expense of Maryland taxpayers. The influence of the abortion industry in developing school policy and curriculum has degraded the role of parents in their children's healthcare decisions. The Maryland Department of Health has willingly served as a pass-through entity for public funds to Planned Parenthood. As a result of the state subsidizing the abortion industry, the number of abortions has increased, not decreased. In their 2020 annual report, Planned Parenthood reports committing 354,871 abortions just last year, nearly an all-time high, while their family planning and prenatal services have declined by 75%. This bill will allow the Department of Health to indiscriminately expand taxpayer funding for abortion through monies intended to benefit school-based health centers. Abortion activism has no place in our schools. For these reasons, we urge you to protect Maryland children by issuing an unfavorable report and leaving the existing oversight and regulatory structure in place. Thank you for your time and consideration.
I guess I'm in shock because we're talking about poor kids who don't have medical care or the ability to get to medical care, not being served at all. And most of them aren't about to be parents. They are kids who don't have their immunizations, kids who can't get a dental appointment, kids who have asthma and aren't able to pay attention in school because they're about to have an attack. So what about this bill leads you to think that this is about abortion?
Well, Senator Kelly, we absolutely agree with you that children deserve quality health care and access to quality health care. That's something we support. But I think the codependent role between the State Department of Health and the abortion industry inhibits children getting the health care services that they do deserve. It's a distraction from the real work the state could be doing to provide those important health care services. And unfortunately, because the role of the school-based health centers have been expanded to include comprehensive reproductive health care, education, and referral under Maryland law, comprehensive reproductive health care necessarily includes abortion as health care. We disagree. We do not believe that abortion is health care, and we deserve that. We believe that women and pregnant girls deserve better options, and the state should prioritize those better options, Senator.
Senator Hayes. Okay, Senator Hayes.
Hey, Madam Chair, like you, I'm a tad bit confused. Ms. Lord, are you saying that they've already extended to comprehensive, but they're currently under the purview of MSDE? This bill hopes to switch it to MD8. So I'm curious, we're trying to avoid what's already happening. I'm confused by the testimony. If you could help me understand, it sounds like this has happened regardless of where the jurisdiction lies already. Is that what you're saying?
Senator Hayes, you are correct. This is already happening in Maryland public schools and through our school-based health centers. We're concerned about the expansion because of the removal of the oversight provided by Maryland State Department of Education, which of course the Department of Education functions more independently. For one thing, the board is appointed by the governor and approved by the Senate, as you know. Then the superintendent is appointed by the board. And at the local level, parents have the ability to elect their school board members and hold them more accountable. That's not the case with the Department of Health. And so we'd like to see the oversight of the Department of Education remain in place with the assistance of the Department of Health.
Thank you, Madam Chair.
Okay, are there other questions? Okay, if not, then that ends the testimony on this bill, and thanks to everybody. Okay. We're going next to Senator Hester, Senate Bill 857, Maryland Community Health and Public Safety Center of Excellence, establishment of.
Thank you so much, Chair Kelly, Vice Chair and members of the Senate Finance Committee. For the record, Senator Katie Fry Hester. Hold on, I just got signed out of my, it's very weird. I just got technical difficulties. I'm here today to testify on Senate Bill 857, and I'm testifying on it as amended. So you should have received an email from me before noon this morning, and I also tried to get you a hard copy with the interlineated copy and also the a clean copy of the bill. So you might want to find that. It might help it today's presentation go a little bit easier. For context, over the past 2 years, I've had the honor to serve with the Lieutenant Governor as co-chair of the Public Safety and Judicial Systems Subcommittee of the Lieutenant Governor's Commission to Study Mental and Behavioral Health. And that has offered me, an insight into so many aspects of mental health that I hadn't seen before. Many of the individuals who have testified before us are stuck in a cycle that leads to incarceration due to untreated mental illness. So this year in 2020, Dr. Linda Vanesky, who is my co-chair from the Department of Public Safety and Correctional Services, and Steve Hsu, who is the chair of the Opioid Operational Command Center and the co-chair of the Committee on Crisis Intervention, we worked together to host our first state summit on mental health and behavioral health in the criminal justice system. And this was made possible by a grant that we went after that brought in a great group of experts to convene this first state summit. I was really happy to get that grant from SAMHSA. The summit itself brought together over 200 stakeholders from across Maryland to evaluate strengths and areas of for improvement in mental and behavioral health across the entire justice system. So beginning from the very beginning, where you're just in the community, to potentially your first interaction with law enforcement, through the court system, through release and parole at the end of the criminal justice system. So once we had those 200 stakeholders together for 2 days, working across our state to look at best practice and where the gaps were, the consultant we worked with through the grant developed a report. Now that report is linked to my testimony in your bill file, and it includes 13 recommendations. These recommendations strengthen, outline how to strengthen services, close gaps, and create a continuum of care. We all agreed that in order to make sure that this report did not just sit on the shelf, but became actionable, and these 13 recommendations move forward, we needed to create, some kind of body that would be accountable for getting these recommendations done and really be accountable for diverting folks with mental illness from the criminal justice system. So what does this bill do? Senate Bill 857. It creates a center of excellence, which we developed after reviewing similar centers of excellence in Ohio, Florida, Virginia, Oregon, and Michigan. And there are a number of tasks for this center, and they're outlined in the bill. I like to think of them in 3 different buckets. The first bucket is strategic planning. So to help the state of Maryland to reduce incarceration and increase treatment of justice-involved individuals with behavioral health disorders and track the state's diversion activity. So that's the first broad bucket. The second is to work with stakeholders to identify grant funding that would support the missions of the center. So we're thinking about going after grants for behavioral health crisis grants, training for 911 operators, peer support services, behavioral health screenings, relevant scholarships. That's the second bucket. And the third is to share best practice and provide technical assistance to local jurisdictions, including the second piece of this grant we already secured, which is to train 50 folks across the state how to do this sequential intercept model training so that they can do it at the county level. So that's what the center does. There's a second piece to this legislation, which also requires that local jurisdictions develop 2-year behavioral health and public safety plans in collaboration with their local behavioral and criminal justice planning bodies and key stakeholders. So they would just use their existing management bodies on the ground with technical support from the centers to make sure that they're doing everything they can at the local level to support these goals. I wanted to point out that because of all the stakeholder engagement we've done over the past year, we have a number of letters of support. And I want to tell you that the Lieutenant Governor, Boyd Rutherford, has written in with a letter of support, as well as the Governor's Office of Crime Prevention, Youth and Victim Services. So we're seeing 2 letters of support from the administration. We also have numerous advocacy organizations, including NAMI, Mental Health Association of Maryland, the chapter of National Council on Alcoholism and Drug Dependence, as well as the Anne Arundel chapter of the NAACP and the Maryland Office of the Public Defender. They are all in support of this bill. So just to bring it home, colleagues, I think this is an incredibly important bill for the state of Maryland. Here's just a few reasons why you should vote favorably on the bill if I haven't convinced you already. First, according to the Maryland Alliance for Justice Reform, 39% of local jail inmates in Maryland have a mental health disorder. That's almost 40% of inmates have a mental health disorder. Second, it's estimated that 9 out of 10 of those individuals are also struggling with substance abuse disorder. Third, unfortunately, the jail and prison stays of these individuals are likely to be longer than an average incarcerated individual. And finally, these disparities are only compounded for our Black and Brown community members by the pre-existing racial disparities we know exist in the criminal justice and behavioral health systems. Colleagues, we have a systematic problem that fails everyone in our behavioral health and criminal justice and public safety systems, and it requires a systematic solution. And while the starting of this center is by no means a panacea, having an office dedicated to improving the nexus of behavioral health, criminal justice, and public safety outcomes for some of the most vulnerable community members will set us on the path to a more just and equitable future. For these reasons, I respectfully request a favorable report of Senate Bill 857, and I believe I have several witnesses signed up, starting off with NAMI Maryland.
Let me ask if there are any questions of the sponsor.
Of course.
Okay, then let's go to, just a minute, Tamara Cyphers. You are the lead proponent, and so you have 5 minutes. Other proponents and opponents, if there are any, will have 2.5 minutes each. Okay.
Thank you very much, Madam Chair. And members of the committee. Maura Cyphers here on behalf of the National Alliance on Mental Illness Maryland chapter. One of NAMI's top policy priorities this session is diverting individuals with mental illness from the criminal justice system. NAMI fights for people to get help and not be put in handcuffs. And in a mental health crisis, people with mental illnesses frequently encounter police rather than get medical attention. Like you heard the sponsor mention, close to 40% of incarcerated people have a mental illness, and 1 in 4 police-involved shootings are believed to be with a person with mental illness. And, you know, as a result of our lack of a comprehensive system-wide, you know, behavioral health crisis response system, people with mental illnesses are overrepresented in the criminal justice system. And we believe every community should have robust crisis services that decrease or eliminate the potential for interaction with law enforcement as a first response so that folks experiencing a psychiatric emergency can receive help and avoid that criminal justice involvement. One way to do that, and one thing I'm really gonna, I think, stick to on this bill is utilizing the sequential intercept model. So Senator Fry Hester touched on the summit she was able to bring together in November, and NAMI is so excited and strongly supportive of this bill and this approach, because the sequential intercept model, or SIM framework, it helps communities address diversion, and it helps us look holistically at behavioral health treatment and responses across systems. So criminal justice, behavioral health, addictions at the intercepts. And an intercept is a juncture where interventions that could prevent people with mental health issues from entering or penetrating deeper into the criminal justice system. And so, you know, the way we think and talk about intercepts is like a filter. So ideally, these interventions are front loaded to intercept people early in the system rather than on the back end. So if you're in jail and receiving your behavioral health or mental health diagnosis and you're starting treatment, which in Maryland, you're 2 times more likely to start in a criminal justice setting than you are in a healthcare setting, then we know we've got more work to do on community-wide crisis response. And so Intercept Zero is community services, looking at what we're providing. Intercept One then is law enforcement and that response. And you guys have spent a lot of time talking about that. And then initial detention, court hearings. So are there ways to screen, or can we train lay people and or judges on how to recommend diversion and programming at that? Reentry, which is a big one, and then community corrections. And one key component of SIM is mapping. And it, you know, when you read about it, it's dry. It sounds kind of like a glorified work group, but it's actually really important. Mapping brings together community partners and a broader stakeholder group to identify community assets, identify resource issues, including overlaps, gaps, bottlenecks, hidden resources, and barriers that can attract implementation. And you guys get the idea. It's escaping me a little bit right now, but there was a small work group, I think it was in Baltimore County, with the behavioral health community, focusing on folks who are in crisis and law enforcement. And this is just a really small example, but calling law enforcement when someone was in a crisis because the courts were closed. And so after 4:30 at 5, you couldn't get a judge to issue an emergency petition. And so the judges and law enforcement and advocates just locally worked out. And the judges said, well, you can come to our house or call us at home and we'll help you file that EP and get someone to the emergency room. So they're not going to jail, and we can reduce law enforcement interaction. And so that's just one really small granular thing that when folks across systems are talking to each other, we can really do more transformative systemic change to help address these concerns. So I think, you know, there are a million more great examples from cities and states implementing SIM and focusing on different intercepts and how that's improved diversion and response to individuals with mental health issues. So thank you so much to Senator Hester for bringing this bill and her legislation, but also for securing the grant from SAMHSA to have the SIM Summit in the first place. And NAMI asks for your favorable report on this bill.
Thank you. Are there any questions for this witness? Okay, we're going to Darrell Frazier.
Yes, good afternoon, Madam Chair, Vice Chair, and members of the Finance Committee. My name is Darrell Frazier, and I have the pleasure of serving as the Policy and Community Engagement Manager for the Mental Health Association of Maryland. The Mental Health Association of Maryland is a nonprofit education and advocacy organization that brings together consumers, families, clinicians, and advocates that advocate on behalf of all aspects of mental health, mental illness, and substance abuse. I want to start off by thanking Senator Hester for introducing Senate Bill 8 857 and from working with the Mental Health Association in Maryland on amendments that will make a strong bill even stronger. The Mental Health Association of Maryland supports this bill in its goal of furthering a sequential intersect model, SIM, framework to divert individuals with a serious mental health and substance use disorder away from the criminal justice system. The SIM is a system planning framework to improve outcomes for people with behavioral health needs who become involved with the criminal justice system. However, the model has never been implemented with an eye toward ensuring that the resulting strategies and policies are equitable across populations, particularly those minority populations who will be mostly impacted. Social, economic, and environmental conditions where individuals live, work, and play significantly impact an individual's health and healthcare, including access to mental and substance use disorder treatment services. Public health officials refer to these conditions as a social determinant of health. The problem is even worse for certain populations of society. Racial and ethnic minorities have less access to behavioral health services than their peers. They are less likely to receive needed care. They are more likely to receive poor quality care when they are treated. Troublingly, although these results in a desperate minority criminalization, incarcerated people of color are less likely to be identified as having health behavioral disorders and are less likely to receive treatment. For that reason, we very much support the amendments that, one, require the center to carry out its duties with an eye toward reducing racial disparities that lie at the intersect of behavioral health and criminal justice, and two, require that all strategic plans are required by the bill include a racial impact analysis. Thanks again, Senator Hester, and again, we would like to urge a favorable report on Senate Bill 857. That concludes my testimony. Thank you.
Thank you. Are there any questions for this witness?
Madam Chair, Senator Hayes.
Yes, Senator Hayes.
But I just wanted to acknowledge Darrell and his work. I've known him for a number of years, and he's continued, to work throughout the city to empower others. And so thank you, Darrell, for your testimony today. Thank you, Madam Chair.
Thank you, Senator Hayes. I greatly appreciate that. Anything I can do to advocate on behalf of Baltimore and the state of Maryland, I will do my part. Thank you.
Okay. We're going next to Ann Seacott.
Good afternoon, Madam Chair, members of the committee. I'm Ann Seacott, and I'm representing the National Council on Alcoholism and Drug Dependence, the Maryland chapter. And we support Senate Bill 857 with the sponsor's amendments, and we thank the sponsor for bringing the bill forward. According to the Substance Abuse and Mental Health Services Administration, SAMHSA, the sequential intercept model helps communities identify resources and gaps in services at each intercept opportunity and develop, and develop local strategies, local strategic action plans. NCADD hopes the Center of Excellence, in collaboration with the Behavioral Health Administration, will make strong recommendations, especially at the Intercept 0, which ideally focuses, as previous witness talked about, on opportunities to help people with mental health and substance use disorders who are in crisis before law enforcement becomes involved. The focus of crisis services that this committee knows very, very well needs to be on having services available for people where they need it and when they're ready for it. These health crises must have a health care response. Unfortunately, when there's an overdose right now in Maryland and someone calls for help, the police show up as part of the response every time, and they treat the situation like a crime scene. This makes people not want to call for help, and people die as a result, but we can do better. In terms of the other intercept opportunities, we think there are great examples, including the Law Enforcement Assisted Diversion Program, options for people to get treatment instead of jail, and a growing amount of re-entry support. A Center of Excellence could help identify where the gaps exist and the resources that are needed to fill them. Being better prepared with appropriate resources is very good policy. We also very much support the efforts that address developing a workforce that is better equipped to respond appropriately to crisis situations. Thank you. We urge a favorable report with the sponsors' amendments. And I'm sorry that Senator Benson isn't around for me to say happy birthday to her. Please pass on.
Thank you. Okay, are there any questions for Ann Seacott? Okay, we're going next to Ida Ate Benison.
Honorable Chair Kelly and members of the Finance Committee, my name is Ida Ate Benison.
I'm the lead contact tracer within our Health and Human Services Department at CASA, the Mid-Atlantic region's largest immigrant survey and advocacy organization with over 90,000 members statewide. CASA provides a wide range of services varying from employment placement, workforce development and training, health, referral, and legal services to Latino and immigrant communities throughout the state. In this effort, CASA is also committed to empowering members to work collectively to advocate for solutions that address structural inequities present in these very same fields. As such, on behalf of my organization and our members, I urge you to vote in favor of Senate Bill 857, which will help significantly advance efforts to create effective diversion programs aimed at reducing the number of the incarcerated in our state with behavioral health needs. The appalling number of individuals in our prison system with behavioral health needs is a shameful reminder of how we have chosen to deploy our law enforcement to address situations that do not require such measures, and rather call for much more strategic interventions involving behavioral health and social service infrastructure. This bill seeks to assist those jurisdictions interested in using data and best practices to help create effective diversion programs. The Center of Excellence proposed here will act as a central repository of resources for the purposes of improving our behavioral health and justice system. Additionally, the legislation as proposed will generate more opportunities for data sharing between departments and communities providers that will allow for greater data-driven programmatic evaluation and implementation. As an organization working daily to address racial and ethnic disparities, we believe in the efforts outlined in the legislation. Understanding the data behind how communities of color are disproportionately impacted is vital to creating an effective diversion system that is inclusive. Such an evaluation must take into consideration culturally competent care. There has long existed gaps in the availability of that type of care to the immigrant community. As such, we hope this legislation will help define standards of practice that will increase accessibility to those most vulnerable. For the reasons outlined above, we ask for a favorable report for Senate Bill 857. Thank you to Senator Hester and Senator Smith for championing this bill.
Thank you very much. Are there any questions for this witness? Okay, we're going next to Mary Pizar.
Good afternoon, members of the committee, Madam Chair, Mr. Vice Chair. My name is Mary Pizzo. I am the supervising attorney for the Forensic Mental Health Division of the Office of the Public Defender. We support with amendments the creation of the Center for Excellence, and we do appreciate that the drafters took our amendment suggestions very seriously. And so for that reason, we went from just an informational to a favorable with the amendments. This center will operate to develop models diverting individuals with behavioral health illnesses, both mental illness and substance use, away from criminal involvement and towards the necessary treatment and services, because the mentally ill do not belong in detention facilities. And for too long, that they have been the hospitals. In my role in the Forensic Mental Health Division, I consult with attorneys all over the state who have clients who are mired in the criminal justice system solely because they have a mental disorder driving their behavior. And this, I got another call just last week about this same thing. It is very frustrating and heartbreaking to hear when a family member, believing it is the only alternative, calls the police for help in managing a mentally ill relative in crisis. Sadly, it is not uncommon that the help results in handcuffs and then charges for assault on a police officer. A very ill individual ends up in the place least likely to be of help whatsoever. And the next professional most likely to become involved is a public defender rather than a mental health clinician. We really would like to work ourselves out of a job in this case. The Center for Excellence will support the development of a sequential intercept mapping system, the purpose of which is to provide alternatives to law enforcement involvement in incarceration when behavioral health alternatives more appropriately resolve these human problems, and ultimately long-term improvement in community safety and comfort. And we strongly urge an emphasis on intercept zero, meaning intervention before any police involvement. The public defender, the Office of the Public Defender supports Senate Bill 857 with the amendments, and we would ask for a favorable decision on that. Thank you.
Okay, maybe you could help me with one principle, I guess I'll call it, that I've heard from 2 or 3 of the witnesses so far. And I want to be sure, since Senator Hester doesn't get to take this to the floor, some one of our members, and maybe I will. And we understand generally everything you're saying, and it sounds good. But tell me how you would operationalize sequential intercept model or sequential intercept mapping system. I've heard those 2 things. And I want to be sure, because somebody who's picky in the general body is likely to get up and ask, and how do we define it?
I appreciate that question, Madam Chair. We do have in our office, we have the advantage of having a group that's working on a grant in Baltimore City that is trying to intervene very early with clients who have had multiple arrests of very minor misdemeanor issues. So they never get to the point where sort of my office kicks in where we can give them assistance. So we're working with them on that early end. In doing that, the coordinator of the grant, and I'm sorry she did sign up to testify, but unfortunately she didn't. She did a very intensive mapping, sequential intercept mapping for Baltimore City. What that does is sort of find out in each sort of intercept what services are available at that level, and then how they can be disseminated to the people who need them most. So early on, intercept zero, what we want to do is have some crisis intervention centers, which I'm hoping this will be discussed greatly in the center, or sort of community services that are available. Then moving on to intercept one, looking for alternatives after an arrest to keep them out of the sort of court and see what's happening there. And of course, by that time, the public defender may be involved, and we would certainly like to help in finding those issues. And then as it progressed through the later intercepts, we look at different ways that, we as public defenders, we certainly try and, especially in my job, try and find mental health alternatives to prison sentences, jail sentences, lengthy probations, or other kinds of things that are very difficult for people of this with these problems to manage. So I don't know, I'm not sure if that answers your question directly, but I think the public defender's office can be very well involved, and we already are involved as members of the Behavioral Health Advisory Council with the Department of Health, and we're very involved in trying to seek alternatives.
Thank you very much.
Madam Chair.
Additional, wait a minute, I've got an additional witness I want to call, Charlotte Davis. Favorable with
Good afternoon, Madam Chair, members of the committee. I'm Charlotte Davis. I'm the Executive Director of the Rural Maryland Council, here in support with amendment of Senate Bill 857. And we thank the Senator for including rural communities as one of the components of the bill. We know that access to healthcare in general for rural areas is a great issue. Several of our rural communities are medically underserved, and we do see provider shortages, particularly in mental health. So we think that this bill is a step forward in connecting those sparse resources to those rural areas, to the local expertise for where it is. So we are here, and we would encourage the the center to, when it does their strategic plan, to include a local assessment of capacity, because that is a really big challenge, is the lack of beds, publicly funded beds, particularly for substance abuse. And then in the collaboration section, include the local health improvement coalitions, because those are the local stakeholders that understand those capacity and access issues, and particularly transportation. So we're delighted to be here, and we ask for your favorable with amendment support of Senate Bill 857.
Okay. Now let me ask somebody, does sequential intercept model mean that you've got several steps going up kind of a ladder from maybe minor interventions given the nature of the presenting problems to very severe, and that you have worked on appropriate responses to each level in a ladder of need or something like that?
Madam Chair, I can answer that question. It's a great question, and I probably should have started off with this graphic. I'm not sure if you guys can see it. No, you can't see it. It's on page 4 of the report, but it defines what the sequential intercept model is. It's really a planning tool. And so intercept 0 is the community services. And intercept 1 is where you might encounter law enforcement or a 911 call. And intercept 2 is where an individual could encounter initial detention or court appearance. Number 3 is jail or specialty court. Number 4 is prison reentry or jail reentry. And number 5 is parole and probation. So though it's the intercepts of the individual with the criminal system. And I just want to say that this report, there's a lot in here, and we go through each of those 6 intercepts and recommendations for Maryland. I'd be happy to talk with anybody who wants to do a deep dive.
I think you're clarifying. I just wanted to be sure we understood.
Okay, thank you, Madam Chair.
The level of need can vary from very minor, and it progresses up, and you've got to do more and maybe involve more community partners or involve them differently depending upon the, okay. All right, are there any other questions? Okay, if not, then okay. All right, that ends the testimony. It's very interesting. We hope that you're going to get the funding and other assistance that you need in order to implement this mapping system.
It's got a very small fiscal note because the department says they have lots of the pieces in place. So thank you so much, Madam Chair.
Okay, thank you.
Take care. Bye-bye.
Okay, we're now going to Senator Hayes, Senate Bill 784, State Anatomy Board claimed cremated remains, provision without payment of cost. Senator Hayes, you're on.
Yes, ma'am. Good afternoon, Madam Chair. I'm going to take a risk and be very, very brief, given that there's no opposition. And this is a very simple bill. As you all remember, last year, Senator Carter brought a similar bill that had some deficiencies in drafting. This bill simply provides an opportunity for individuals to claim cremation if they, without associated fees, if they demonstrate a financial hardship. Committee, I urge a favorable report.
Well, when you say claim it, you mean people die, let's say during this COVID-19 pandemic, they don't have another plan for disposal of their bodies once they are demised. And so they would do what, leave something asking the.
Yeah, so if they, and this is simply codifying what's already in practice right now. If an individual show or able to demonstrate that they have a financial hardship, instead of the State Anatomy Board disposing of those, the ashes, they would qualify to have them turned over to our family member.
Would have them turned over, they would
be able to have them turned over to a family.
I haven't looked for your fiscal note, but what does that look like?
There is no fiscal note. It simply codifies what's already in practice.
Well, even if it's in practice, when you do this now, you're going to get some fiscal note. because so these are people not willing their body to science to be studied like I have done by the anatomy board. But people who simply need.
I just want it to be simple because I know we have a lot more, but I'll read the fiscal note, Madam Chair. This bill requires the state anatomy board to provide the cremains of a descendant who is cremated through the state cremation process in a suitable container in the descendant's relative without requiring the relative to pay any cost. If the cremains have not been buried at the state burial grounds, and 2, the relative has shown hardship. The state effect, since the bill generally codifies current regulations and practice, there is no material, fiscal, or operational impact on the state autonomy board. The local effect is none. The small business effect is none.
Okay, well, that's given the frequency of use of this modality right now when you don't have an official program. The minute a lot of people find out that you can do nothing, you don't need insurance, you don't need to think ahead, you don't need to leave any documents saying what preferences are, what your family or you would have paid for, that you could see in a pandemic like this, the lines around blocks and blocks and blocks. That would be the way to do it. There's going to be a fiscal note if you make this a state policy, don't you think?
Yeah, and so in most cases, if one doesn't, if there's a, let's say, I don't want to say body, right? It sounds so impersonal, but.
Well, that's what it is.
For lack of better words, if there's a body that is in the possession of the state anatomy board, and especially if it go unclaimed after 72 hours, the body is under the exclusive control, and oftentimes they may use the body that's left over for research and other things. Once they've exhausted that process, they typically will have a cremation of the body, and if no one claims it, they just throw it away, right? They dispose of it in their best, whatever it is. This is just saying, instead of getting to the eventuality that you may simply just trash, someone ashes or remains, that if there is someone that claim them and they don't demonstrate, if they demonstrate that they have financial hardship and economically they just wouldn't be able to, because otherwise if they cannot demonstrate financial hardship, what happens is you still have to pay for at least the transport. Even if it's cremated, you still have to pay for the transport of the actual body to get there. What we're saying is if they demonstrate the financial hardship, they wouldn't have to pay those transport fees. Otherwise,
if you got up to maybe 2,000 or 3,000 such bodies per year, and I believe in a lot of our jurisdictions, you'd end up with many, many more than that. If this became the law, I think they'd be overrun. And I'm just trying to understand how it would work. Though they didn't, let's see, the health department, the anatomy board says they're favorable. Is somebody here from the anatomy? No, they only gave written.
Yeah, there's no opposition. I thought that, and I ran a risk. I took a risk in trying to be brief because I know we have other stuff on the agenda.
Okay, all right, we'll talk offline.
Yes, ma'am.
Yeah.
But I do have a panelist who works in the funeral industry that also may be able to provide some additional clarity.
Well, Kenji Scott. Where's Scott?
Kenji.
Mr. Scott.
Are you frozen?
I can see Mr. Scott, and he looks like he's unmuted.
I know, you can speak, Kenji.
Scott. Mr. Scott.
He hears.
Okay, he isn't hearing us.
Sorry. Maybe.
And he was your 5-minute person.
Right.
With the anatomy board.
No, he's with the firm. Maybe if I call him.
But let me ask if you would give me the right to do something. I see Dan Moorheim sitting out there muted probably for something else. He's a physician. Could I ask Dan?
We couldn't hear you. You want to test it?
About how
I'm trying, I don't know what's going on with my sound.
That's okay. You want to go ahead now? Madam Chair, I have him on speaker.
Okay.
Testify.
Okay.
Go ahead,
Okay,
Kenji.
Mr. Scott, go ahead.
Yes, sir. Madam Speaker, thank you for allowing me to testify today. I'm testifying on behalf of this bill because I've worked with a lot of families in the city of Baltimore. I sell caskets and urns. Over the last several years, you know, Baltimore City has experienced 300 plus homicides a year. When I started providing services to the family of homicide victims, I did not know that there were so many families that could not afford to bury their sons. And so when groups like Maryland Criminal Injuries and Roberta House will recommend families to me, it wasn't so much for them to buy an urn or a casket. It was because they needed assistance, because I had a reputation in the city for being able to help families and make things happen. But I wasn't experienced with trying to find resources to bury people's children. And the only resource that was available was through the Department of Social Services. And they only provided those services to families who had received some form of benefits, whether it was Medicare or food stamps. Well, not every family in the city receives food stamps or Medicare, and that benefit is only $850. So sometimes I found myself helping families raise money just to bury their children, and that's difficult. And then people started coming to me who were not families of homicide victims. They were poor people who were not able to afford life insurance or not able to get life insurance because they were like me. I'm HIV positive, so I can't get life insurance. So at the end of life, I'm fortunate because I'm able to pay $45 a month for a $15,000 policy that I had to wait 2 years in order for that policy to activate. I couldn't die before 2 years. My family was out of luck. But then again, I'm still blessed because I got caskets. That's not the case with families across the state of Maryland. I started getting calls from people from Montgomery County, from PG County, and they were not just Black people because predominantly the people I started out working with were Black. Then those families started to be white and they were Latinos, and they had the same concerns about finding resources. But I knew people died, and when people were murdered, they went to the anatomy board, and that the anatomy board cremated people who were not able to be buried. The families couldn't claim them. They didn't have the resources to send them to the funeral home. And so the family member would be cremated, but they couldn't get those cremains back because they couldn't afford them. They couldn't afford the fee at the anatomy board to get their family members back. This bill helps families. This bill helps poor families, people who are in need. We talk about traumatization in the city of Baltimore. Madam, there is nothing more traumatizing to be married to a person for 30, 40, 50 years, and then when they die, you can't even claim their cremains because you're so poor and you don't have a goodbye option. You have a one-time option once a year where the anatomy board through some service may have a general service, but that's so impersonal. And I'm only asking that we would, and it's simple. I'm not going to keep you long. It's simple. If we could just give those cremains back. I'm originally from the state of Illinois. And when people die in the state of Illinois has a burial fund for poor people. The state of Maryland does not have that. This is a quick fix. It's needed. We can afford it. We can do it. We're already doing it. We're simply asking that the anatomy board would give those cremains back, and this would be the first burial fund. This would set precedent in the state of Maryland. We never did it before. We need to do it. This would be our way of burying Marylanders who cannot afford to bury themselves.
Let me ask you something about how many families have you personally been helping per year in this way?
And it may be, and Senator Hayes may be able to help me with some of those numbers because he's the person I call when I need you because he's the over at TSS. I probably see about 100 families a year.
Okay. Let me say this. When you pass a law that says this, it wouldn't be just that 100. everybody anywhere in the state of Maryland that would need the anatomy board to serve this purpose would all have equal rights to it. And remember, the anatomy board is there to do two things. They teach medical students the anatomy of the body so they can learn. They also deal with homicides or suspicious deaths where you need medical analysis to determine if something untoward has happened or if the person has died naturally and that kind of thing, and to assist the courts in working through that. My concern is that I think it would be totally unconscionable, though, for us to sit and expect that the anatomy board for all the poor people in the state of Maryland, because this is a statewide bill, and you couldn't make it jurisdiction specific because it's a state agency that you're talking about. And they have time, if they took this on, to do what their job is, that is to teach medical students and people who are going to be physicians and so on, and to deal with all the police work and public defense work and so on that they would have to deal with in order to carry out what we already fund them to do. So that's what my concern is.
I'm not asking for it to just be Baltimore. That's why I mentioned other counties. When poor people die, they don't just go to a funeral home.
Okay, I understand. And I think we need to find a solution. I'm just not sure this can possibly be the solution given what the anatomy board is funded to do. Okay.
You don't choose a funeral home.
Okay, we have come to the end of this particular hearing, and you did a very good job.
All right, thank you.
I see the problem up close. Okay, thank you. Okay, we're going to Senator Kramer, Senate Bill 837, and your lead person is Alan Eason, and that person, is Dan Moorheim. That's Dr. Dan here, and he will have 5 minutes. All your other witnesses will have 2.5 minutes each. Okay.
Thank you for that, Madam Chair, Mr. Vice Chair, members of the committee. Pardon me, Ben Kramer introducing Senate Bill 837. Colleagues, I have had the pleasure to represent the Senate on the State Advisory Council on Quality Care at the End of Life. The council is comprised of very talented people, well-versed in the issues that the council addresses. Its members include hospitals, hospices, physicians, seniors advocacy organizations, and healthcare specialists that cover a wide spectrum of interests. Last year, in response to a request from the Senate Budget and Tax Committee and the House Appropriations Committee, the council focused a lot of time and effort on developing a very thorough report with recommendations to increase the number of residents who have completed advanced directives and best practices for making the directives readily accessible when needed. Less than half of Marylanders have completed an advanced directive, and the numbers of our minority residents who have done so is a fraction of that number. The bill before you represents the work of the council that requires legislative action. So what does the bill do? It requires that the Maryland Healthcare Commission coordinate with a broad range of healthcare entities in the state to promote and facilitate the use of advanced directives by our residents. It also requires insurers, nonprofit health service plans, and HMOs to offer advanced directives to their members or enrollees during open enrollment and periodically thereafter. Finally, the bill requires that the Department of Health, working with local jurisdictions, develop and implement a plan to provide people receiving a COVID-19 vaccine information about advance directives. As I previously mentioned, the council has a broad membership of representation in the healthcare fields, and as such, the bill has very broad support across those interests. The witnesses speaking today and the large number of supportive written testimony reflects that. I am also very honored to have our former colleague here in the legislature, Dr. Dan Morheim, speaking in support of the bill today. I will also point out that there is no fiscal note associated with this outstanding initiative from all the folks who are going to come up behind me and speak in favor of the bill. So with that, I thank you, Madam Chair.
Thank you. Are there any questions of our sponsor? Okay, if not, then we're going to Dr. Dan. And Dr. Dan, you've got 5 minutes, and the other witnesses will have 2.5 minutes each.
Thank you, Madam Chair. Mr. Vice Chair, members of the committee, it's an honor to be a citizen after 24 years in the General Assembly, be testifying before your committee, and thank you, Senator Kramer. Senator Kramer really outlined the benefits of the bill. I'm going to say a few words about them, and then I'm going to spend my time speaking from my heart and my mind to address some of the concerns that have been raised in some of the letters that have come. But the main benefits, the benefits of advanced directive completion, which every adult over the age of 18, in my opinion, ought to do. And we ratified that in effect in the General Assembly when we passed the National Healthcare Decisions Day Act back in 2016, House Bill 91. But the benefits are manifold. Care is personalized, values are respected, intrafamily conflicts are minimized or avoided. Clinicians know what kind of care patients want. The end-of-life experience, which we're all going to face for ourselves and others, becomes more holistic, manageable, and compassionate. Oh, and also healthcare costs are reduced. Now, it's a tough issue because people avoid it. It's understandable. But in regards to this legislation, there are ways to say no, but it's more important right now that we would say yes. Everyone knows about our collective reluctance to talk about this issue, but I want to go into my written testimony has the benefits, and I also urge you to watch the YouTube video of Dr. Elizabeth Claiborne, who will be testifying next, but just a few minutes to get her perspective. But let me focus on the concerns that some have raised. The League of Life and Health Insurance voters, League of Life Health Insurers, it's an interesting perspective. First of all, Dr. Aquino, who is the medical director of Care First, supports the bill. In fact, her quote, and she's on the commission, said the document is excellent and very comprehensive, quote unquote. They write that it do not feel it's the right approach because this would limit the number of kinds of options of advanced directives. Nothing could be further from the truth. There are many options of advanced directives, and our one approved electronic health directive approved through the Maryland Healthcare Commission allows any type of form to be updated. And then in their recommendations, they go on and request a task force to meet and describe advanced directives. That was accomplished in House Bill 557 in 2004, enacted by the General Assembly. Further, it's important to note that on January 28th of 2021, just a month or two ago, CMS announced Medicare Advantage plans as part of their wellness and healthcare planning will be required to provide advanced care planning, meaning advanced directive completion, which are free legal forms, as part of their value-based insurance design. In other words, this is coming at the federal level anyway. So why don't we get a jump start on this? The requirements are going to come. We should do it now because it's important for Marylanders. I was surprised by the county health officers who had concerns. And they write, and I quote, that telling people about it, it's a really good opportunity when people are for COVID vaccines for a couple of reasons. One, they're thinking about healthcare anyways. Everybody knows that there's risks here. And after you get the shot, you have 20 minutes, 30 minutes to sit around. They write that would send an alarming and conflicting message to those who were waiting to get vaccinated. Alarming and conflicting, just the opposite. Comforting and informative, I think, would be a better way. They also concerned about an information sheet that's already been written, and there are many versions of information sheets already available, and our state council can certainly do that. So their concerns really make no sense to me. The Maryland Healthcare Commission writes that not too many people have signed up on the advanced directive forms that are out there electronically. Well, that was what the bill solves. That was the charge, and it solves. So that's the sort of a circular reasoning. So they've done a good job, but really the problem with having electronic advanced directives and electronic health records is it's only in your record. I'm in the LifeBridge system, Madam Chair, and if I happen to go to Anne Arundel or Hopkins or someplace else, they don't have it. It has to be, a clinician has to be able to see that in the moment. When I work in the ER, that's what I need to see. I want to close with a quick story. If you can allow me just a few seconds past. This changed my life many years ago. I was working an ER shift, and an elderly woman who was living alone was found on the floor, brought into the emergency room. And it was clear right away that she'd had a major catastrophe, a major neurological catastrophe. And the call went out, and we've been all on the receiving end of those calls, that someone we love is in the emergency room. And she and family members start trickling in, and I see this battle starting to occur with the family in the quiet room as I'm shuttling back and forth between keeping them informed of our progress with their loved one, what was going on. Turns out she had a massive intracranial hemorrhage from which there was no recovery. We got all the consults. And when I went into the room, I mean, all hell was breaking loose. It turned out, and people who knew her best said, let grandma die in peace. And people who were around less often said, you do everything for her. And, you know, sometimes when families get together, it gets intense. It turned out she completed an advanced directive. So I got the copy of it. It was given to me, and I read it and said, if I'm in an extreme state like this, no heroic efforts. So I'm in the room, and they're screaming and yelling. Finally, they all quiet down. They look at me. It's time for the doctor to say something. And I have the form, and I read it to them, and I say, I'm legally and honor and ethically bound to follow this. So I'm going to go in the room, and I'm going to disconnect the machinery and the ventilator and the medicines. And you can come in there with me if you want. We think at that moment it might get more explosive, just the opposite. Everybody quiets down. The burden of this decision was taken off their shoulders. We go into the room, I disconnected everything, and I watched the family. I moved to the back of the room and watched the family. They gathered at the head of the bed. They held her hand, stroked her brow, whispered in her ear, said some prayers, heard some hymns being sung. And then she died peacefully in about an hour. It took me a few days. I had to go back and finish the rest of the shift. And it took me a few days to process all of that. And what I realized is we're a very me-oriented culture, but this is not about me. It's about the people I say I love. I will complete this paperwork to not have my family left in the lurch, siblings fighting, parents and siblings fighting, and so on. I don't know that woman's name. I never got a chance to talk to her, but she changed my life and put me on the trajectory that brings me to you here today to ask you to vote favorable on this bill. Thank you very much.
Thank you. Are there any questions for the Senator Feldman?
Yeah, Dan, it's great to see you. I did want to just congratulate you. I know that you just wrote a book recently on this very subject, and I actually watched you, your NPR interview, regarding that book. So I just want, Madam Chair, to congratulate Dr. Morheim on that, and tell him keep up the good work. But I did listen to your half-hour interview on NPR. You sent me the link, so thank you.
That's great. Well, I didn't get that experience, but he's working with MedChi on issues like this, and I saw a MedChi publication where there were a range of positions on the issue, and he had a good essay there too.
Thank you. And I am speaking for MedChi, and I would like to brag, if I can, in response to Senator Feldman. Brian, thank you. The book was endorsed by Ben Cardin, Chris Van Hollen, Leanna Wen, who we know, and also Dr. Leon McDougall, who is president of the National Medical Association, the oldest and largest group of Black physicians in the United States, and a whole bunch of other people, ranging from an evangelical Christian minister to a Buddhist meditation teacher. So I'm very proud that those people signed on. Thank you.
All right, we're going to move to the next witness, Dr. Elizabeth Claiborne.
Hello, everyone. Thank you so much for having me here. I was really honored that I'm having the opportunity to speak about a topic that is very near and dear to my heart. Similar to Dr. Morheim, I am an emergency medicine physician. I actively practice in Prince George's County, where we serve a largely African-American population. And when the COVID-19 pandemic hit last year, this again emphasized to me how important the issue of advanced care planning and advanced directives are. Just to paint the picture for you, I've gone on several networks, including CNN and MSNBC, doing interviews that talk about the importance of advanced care planning and how COVID has highlighted that. And the reason it really surfaced in a very powerful way in my personal life is I was pregnant when the COVID-19 pandemic hit. I was 6 months pregnant. I worked through the first wave where we had, a huge number of critically ill people flowing in. And it was very real to me to see people get acutely ill in a very short period of time. And often what would happen is a patient would come in respiratory distress, so they cannot speak, right? They're gasping for air. I might need to intubate them immediately. Perhaps they came from a nursing home and they already looked like they had multiple medical problems. And I would be searching for paperwork that would tell me, do they have an advance directive? And sometimes there would be paperwork, but it would be dated from 3 or 4 years ago. And then there would be a contact number, and I would be scrambling, taking off my PPE to try to call a family member, manage the patient. And oftentimes what happens is that we end up sometimes doing things to patients that they did not want. For example, on more than one occasion, there were patients that I actually intubated because I have to make that decision in the first 10 minutes of someone arriving to an emergency department. And I put a breathing tube in to stabilize them. And then when the dust settles and I can go out of the room and undress from all my PPE and search for a family member and talk to them, I come to find out that that's actually not what they wanted, that they actually had expressed to their family that they would prefer not to be on life-saving measures. And so now I have the additional burden to have to go and kind of undo what was done. And to me, it's a huge disrespect to patients that could be easily avoided if physicians like me, who are working in an acute setting, have easy access to advanced directives. In addition to that, a large number of people just don't have directives. It's more common a story that I'll have to call a family member when I'm telling them their loved one is doing really poorly, and I think that maybe they need to go on a breathing machine, maybe they need medication that's going to support their blood pressure. And when I start engaging them in a conversation, they have never broached the subject with their loved one before. And this is for people of all different ages, because it could be a trauma setting where this is an issue, or someone who was pregnant like me and has something catastrophic happen. And so I think that it's important to normalize advanced care planning and filling out advanced directives as something that everybody should do, and it should be regularly updated. And then what's important and what needs to accompany that is that we need tools as physicians so that I can do my job well. I need to be able to access that information so that the patient has a voice in their care and they can tell me what they want through that directive, and that there's no mix-ups. Quickly, because I know I'm over my time, I do think that this bill supports the correct tools and engages people the right way, because through the insurers will capture more of Marylanders to sign up for it. And then through using an online platform like the ones that have been approved, they will interface with the healthcare EMRs like Cerner, Epic, and CRISP, so that I can have quick access to that information when it matters most.
Okay, you guys are reminding me, I've got all my paperwork for all those things, but I haven't converted them to a digital format.
Exactly. So what do you think would happen?
And I actually got the legislation passed in Maryland that we can recognize all of this done digitally. So I got to behave.
I'm a big proponent of leading by example. When I was pregnant and I was worried about what was going to happen to me, that's one of the things I did. I updated my advance directive. I made sure my husband understood what would happen if I got sick, and what would happen with our baby. And that's why, again, it's for every age.
But I got to behave. Okay. Ted Myerson. Hi, Ted. I haven't seen you for a while.
Senator, it's a pleasure to be in front of you and say hello. I haven't seen you in a while.
Yes.
My name is Ted Myerson. I'm here representing AARP. I'm a former chair of the State Advisory Council on Quality Care at the End of Life. I've been interested in the promotion of advanced directives, it seems like at least 20 years. And I failed. I failed like almost every other person or organization has failed to get a lot of people to sign on to have an advanced directive. And we know the reasons why. I don't want to face my own mortality. I don't want my kids to face my mortality. I don't want to have a meeting with them and talk about it. I'll hide under a rock. It won't happen to me. I'm only 45. I'll live to be 100. Whatever the reasons, they don't and they won't. And unless we change that culture, unless we make it normative, they're not going to do it. And the way you can make it normative is through the insurers. Those are the people who are out there all the time, signing people up, re-signing people up. And if they make it a normative thing, you really should have an advance directive. You can do it for free. It's digital, go online. Everybody's got a cell phone. Everybody's got a computer. If you can do that, if you can have people say, gee, it's normal to have it on my driver's license, you can change the culture. And if you change the culture, it will help. And everybody wins. The patient wins, the family wins, because there's no fights. They know what they want. And I've heard all kinds of economists say the insurance companies will win. So here's a win-win-win. And so AARP hopes that you will give this a favorable report out of this committee. Thank you.
Thank you very much. Are there any questions? Okay. Lastly, we're going to hear from Alan Eason.
Good afternoon. Madam Chair, the prior speakers have covered everything. I'm just to say I'm the chair of the State Advisory Council on Quality Care at the End of Life. And as other people testifying have indicated, the focus is on all of these complex aspects of end-of-life care. And it goes beyond, of course, to things like preferring palliative care and hospice care. And those are things actually, advanced directives can do one or both of two things. One is name a healthcare agent. That's the person who can decide for you when you don't have the mental capacity. And then the other thing is a living will, where you can specify kinds of things that are important to you. They can be what I call on-off switches, or they can just be, a reflection of the things that are important to you. And when I listen to if I may call you Liz Claiborne, that's the kind of, what she expressed was the kind of things that, in 2013, I started doing training on advanced directives. I did it over 70 times for healthcare providers and for citizens. And Liz's story was one that, was part of the training. It's like, okay, you don't have an advanced directive. You've got three children, adult children. Well, under Maryland law, they're your surrogates. But if they don't agree, that's a problem. And so the issue, and something else, I don't know who mentioned it, the importance of revisiting and reviewing. This bill has, it comes from the standpoint of trying to reach out and trying to cause people to be connected with, to hear about, to think about, and hopefully do something. So the State Advisory Council has sent a letter to in fact, to you, Senator Kelly, about it with information. And so I hope that this goes through. Thank you very much.
Thank you. Are there any questions for this witness? Well, we have nobody unfavorable, and it's a great panel that you put together, Mr. Sponsor, and I think this is really very important. We all should be moving forward to behave ourselves. Okay, thank you. We're going next to Senator Klossmeyer, Senate Bill 884, and Senator, the time that you need to lay out the parameters of your bill. Your lead person is Dustin McDonald, and we'll have 5 minutes, and your other witness will have 2.5.
Okay, thank you, Madam Chair. This is not quite such a serious topic as the other. It's medical cannabis visiting qualifying patients. Senate Bill 884 is a very simple piece of legislation that will allow people visiting Maryland to obtain medical cannabis in Maryland, as long as they qualify for medical cannabis in their home state. Under current law, Maryland law, in order to obtain medical cannabis, you must have the approval of a Maryland doctor. Therefore, you may have people visiting Maryland who are unable to access medical cannabis needed for treatment. Patients from other states are also risking transporting cannabis across state lines unlawfully. Patients will still be required to show proof that they can receive medical cannabis in their home state. Many states provide reciprocity in this approach, and it is the most patient-friendly. This approach will ensure that there is no accidental, unlawful activity for patients who use medical cannabis for treatment. With me today, I have Dustin McDonald from Americans for Safe Access and Joe Bryce on behalf of the Maryland Wholesale Medical Cannabis Trade Association. They can explain the importance of granting this reciprocity, and I thank the committee for their consideration of Senate Bill 884 and ask for a favorable report. So I think it was pretty.
Thank you.
Pretty cut and
Are there any
dry.
questions for the sponsor? Not, then we'll go to Mr. McDonald. You have 5 minutes.
Hi, thank you, Chair Kelly, and thank you, Vice Chair Feldman, and thank you to members of the Finance Committee for allowing Americans for Safe Access to come in and offer support for SB 884 today. As the sponsor of the bill mentioned, reciprocity is a huge issue for medical cannabis patients. Medical cannabis patients living in one of 36 states that have an authorized medical cannabis program across this country have to travel from one state to another for business or pleasure at some point throughout the year. And as they do, carrying their medicine with them is going to be a priority. However, oftentimes when you travel, you might have to travel at the last minute and be able to take that medicine with you. There are only 17 of those 36 states that organize a medical program, plus the District of Columbia and 2 U.S. territories that have organized these reciprocity laws that are so important for patients. Imagine for any patient that's not a cannabis patient that's perhaps using an FDA-approved pharmaceutical product that you have to travel into a state and you're not allowed to take the medicine with you that you need to mitigate the symptoms of your health condition or treat the underlying health condition. That's the exact situation that medical cannabis patients are in. And their only alternative, if a state doesn't have a reciprocity law like the one being proposed here, is to choose to transport their medicine across state lines, which is a violation of federal law, or to patronize the illegal market in the state they're visiting once they get there, because they'd be prohibited from participating in the legal medical cannabis marketplace. So this legislation is critical for patients who are going to be visiting Maryland. Maryland every year receives an average number of visitors in the realm of approximately 42 million. So across that population, there's a very large volume of people who need medical cannabis access while they're visiting Maryland. So that's what this bill essentially seeks to address. Now, across those state programs for reciprocity, there's all different versions of them. Some of them require patients to submit forms ahead of time to be able to secure any ability to access medical cannabis in the state they're visiting. Some ask for a fee for those patients. But from the position of Americans for Safe Access, those are all unreasonable barriers to entry to simply access the medicine these patients need, again, to treat their underlying health condition or address mitigate symptoms associated with those conditions. So that's really what this bill addresses and why it's so important. I want to again thank the sponsor for introducing this legislation and urge the committee to pass this bill, and happy to take any questions folks may have.
Are there any questions for this witness? All right, if not, then we'll move on to Joe Bryce. And Joe, you have 2.5 minutes.
Thank you, Madam Chair, members of the committee. My name is Joe Bryce here on behalf of the Maryland Wholesale Medical Cannabis Trade Association. I want to thank Senator Klossmeyer for introducing this bill. As Dustin said, this is an issue for patients across the country. And I think what it does is affords to patients who are coming from other states the same protections that we would want those states to provide if one of your constituents as a patient is going to those states. And the choices that Dustin outlined of disobeying federal law, either in your car or in an airplane to bring your medicine, or even if you're an adult use market to go to a state and then have to pay taxes on a medical product that you are typically not taxed on, aren't good options for patients. So what this bill seeks to do is protect those patients, allow them to purchase here
and allow them the same protections for possession that a Maryland medical cannabis patient has. And so again, I thank Senator Klossmeyer and happy to answer any questions.
Joe, I do have one. I'm just looking at the fiscal note, and the opening paragraph says that our Medical Cannabis Commission would be prohibited from requiring a written certification from a Maryland certifying provider or a commission issued ID card. What about from the state where the person is from?
Yes, so Madam Chair, that is correct, because to impose that requirement, which a patient here has to go through, is obviously time consuming, and they don't have a relationship with that medical provider. But what the bill requires is when you go to secure your medicine in Maryland, you present an identification card and you present documentation that shows you are a bona fide medical patient in the state that you are coming from. So that, just as in this example, the Maryland patient would go to their certifying provider, but then go to another state and just have to demonstrate that they met Maryland's laws to participate in the program.
Okay, sounds good. All right. Are there any questions for this?
Yeah, just
Senator Feldman.
Yeah, Joe, just real quickly, the commission, the Cannabis Commission did raise a couple other issues. I don't know if you would have had access to, I mean, specifically this topic of not being able to verify, in fact, whether the patient, well, specifically they say you wouldn't be able to verify the patient's status in the other state, because I think that's one of the issues. The other is, and maybe Dustin can answer that, and the other with it, we subject our Maryland patients to specific caps on how much they can consume. The out-of-state folks, you would not be able to track that. So, are they in effect able to purchase more over time than our Maryland patients? I'm more interested in the verification issue of how do you kind of prove up or verify that in fact they have been registered legally in their home state. How would our commission be able to do that?
Sure, and I will let Dustin jump in with the experience in other states, but I have seen the commission's letter and I've talked to the commission a few times about this. As Dustin mentioned, there are many different ways that states do this. This, I think, is the most patient-friendly and straightforward approach. The commission has discussed the inability to track the purchases. I understand that that's a potential issue, as well as the verification. I mean, in Maryland, a patient would be required to have a card or their identification number. And so if I were in another state and I was a patient, I would present that along with my driver's license. I think there are likely logistics to work out with the commission as to what states they feel comfortable with. I think some states provide reciprocity to certain states that they are able to verify membership. It's kind of all over the place. They are legitimate issues, and we wanted to start the discussion and try to make progress. So Dustin may have more information on the other
Would you
aspects.
suggest that a 1 or 2 meeting work group with the sponsor and those of you who know the industry might make sense before we bring it up for a vote?
Madam Chair, we'd be happy to do that.
Okay. All right. Any other questions? Thank you very much. Then that ends the testimony on.
Thank you.
We're going next to Senator Benson, Senate Bill 907, Human Services Critical Medical Needs Program Application for Assistance. You have all the time you need to lay out your bill. Your main proponent is Cindy Carter. She will have 5 minutes, and your other witnesses have 2.5 minutes each. All right, so unmute yourself. Gotta unmute yourself. Gotta unmute. Unmute yourself. We can't hear you. Yeah, now you're fine.
Thank you very much.
Thank you. Thank you, Chairwoman Kelly and Mr. Vice Chair and esteemed members of the Senate Finance Committee. Senate Bill 907, Human Services, Critical Medical Needs Program, Application for Assistance, prohibits the Office of Home Energy Programs, OHIP, from requiring a critical, medically vulnerable individual who is at least 60 years old and assisted by a navigator to provide certification from a medical provider of the severe health conditions when applying for the Critical Medical Needs Program, CMNP. People in the Critical Medical Needs Program must work with a certified navigator and be able to get a physician's certification. A physician certification is a document signed by a physician, physician assistant, or nurse practitioner indicating that a person needs to have their power kept on. But those who are 60 and over have often had challenges with technology and are not able to physically get to the doctor's office. That is why Senate Bill 907 with the amendment would allow for those who are at least 60 years old and working with a navigator to apply to the CMNP without a physician's certification up front. As stated, these individuals still must work with a navigator who is trained and certified in the CMNP. There would be no large increase since these individuals are already working with a navigator. There are only 300 navigators across the state. They only work with clients served by their organization. This bill would make the process easier for those individuals who are 60 years and older and issues with getting their certifications quickly. Therefore, I would respect and ask this committee to give a favorable report on Senate Bill 907. Okay, thank you. Do we have any questions for the sponsor? Okay, if not, then we're going to Cindy Carter, who has 5 minutes. That's the lead proponent.
Good afternoon, Madam Chair and Vice Chair and the Finance Committee. I'm Cindy Carter, co-founder of the Critical Medical Needs Program and Executive Director of Cancer Support Foundation. I'm here today in support of Senate Bill 907. First of all, I want to express my thanks and appreciation to Senator Benson for her belief in the Critical Medical Needs Program since 2015. She has worked to keep it going through all the bumps in the road and has made sure it's gotten towards being passed into law in 2019. If it had not been for Senator Benson and Senator Middleton, this state would not have a critical medical needs program to help our most vulnerable. The Critical Medical Needs Program requires those who are in the program work with a navigator. And as Senator Benson said, right now we have, give or take, 300 across the state. It also requires the applicant to obtain a physician's certification with the application up front. Life has changed with the pandemic, and it's become very obvious, especially for those who are 60 and plus, that many times there's a challenge with working with technology to be able to get the physician certification. The same population also has a challenge in getting to a doctor's office to get this form signed and get sent back. Senate Bill 907 with its amendment. Now there was an amendment that was submitted. It was presented in the House, I think it was last week when they heard, a couple weeks ago. The amendment was said that 60 and plus would not be required to have the physician cert up front to do the application. They would be given 90 days, but it would mean the application could proceed with the navigator and go and be processed, and they would have up to 90 days if they needed it to produce the application, which would then go into their folder. We think that is an excellent amendment and really make sure that we're keeping the program to what it's supposed to be, but also making it more available to our seniors. This program does not mean that all seniors across the state are going to be fast-tracked into getting energy assistance applications, because the clients can only work with the navigator who's in the critical medical needs program. This bill will make it easier for our vulnerable seniors to work within the critical medical needs program, to get the grants they need and keep their power on. Cancer Support Foundation supports this bill to make it easier for seniors 60 and above to be able to be part of the critical medical needs program. Thank you.
Thank you. Okay, are there any questions for this witness? Okay, if not, we'll go ahead to the next witness, and that is Debbie Brown. You have 2.5 minutes.
Good afternoon, Senator Benson. Thank you for your support and guidance with this bill. Thank you, Madam Chair, Vice Chair, and members of the Finance Committee. It's nice to be here again with you today on this beautiful early spring day. My name is Debbie Brown, and I'm the director at the Fuel Fund of Maryland. I am here today testifying in support of Senate Bill 907, which would prohibit the Office of Home Energy Programs, known as OHEP, from requiring medical certification when an individual over the age of 60 applies for assistance from the Critical Medical Needs Program. Any reduction in required documentation will benefit clients over the age of 60, since this demographic lacks the most access to technology and would instead streamline the process to provide OHEP assistance. We've honestly really seen this play out more than ever over the last 9 to 10 months with COVID, and how seniors are struggling to even get basic energy assistance application. Senate Bill 907 will not affect any current fuel fund procedures. At present, we accept a verbal or written email statement from a client or their proxy that the client has a qualifying medical condition when considering a client for the Fuel Fund of Maryland Critical Medical Needs Program. The Fuel Fund of Maryland wants to be a partner in the solution to protect critical medical needs patients, especially those over the age of 60, stay safely connected to the power they so desperately need during a health crisis. On behalf of the Fuel Fund, I respectfully urge a favorable report for Senate Bill 907, and thank you again for giving the Fuel Fund the opportunity to testify today.
Thank you. Are there any questions for this witness? Okay, then we'll go to Debbie Brown, and you have 2.5 minutes.
We just heard from her. We're going to Laurel.
Hmm.
We just heard from Debbie.
Oh, I did. I sure did. Laurel Peltier. I'm sorry.
Good afternoon, Madam Chairwoman and Senate Finance Committee. I am very lucky because I get to be an energy counselor out in the field. I work at a fuel fund site. I help primarily older folks get their OHEP applications in, and as a volunteer. So I'm a navigator as well, because every once in a while you get a critical medical needs person. Let me just explain. The OHEP application, it's pretty tricky. But those are documents that the person, the very sick person, has. Now, there's one piece of paper that I'm going to share with you the last story of the guy who I helped. Low tech doesn't even describe this population. And this is a gentleman, he's a stitch. He's was homeless, is doing much, much better, is in a house, is very, very, very sick, has to have an air conditioner on because of his serious COPD. And we needed to get a physician certificate from Healthcare for the Homeless. So 4 weeks, I'm going to explain to you what I did. Now, remember, I'm a volunteer, but I'm a dog on a bone. And I can't really go down there, which I could have driven before, but I faxed it in 4 times, made a bunch of calls, and I just kept going. And I said, okay, how am I going to get this piece of paper in front of this doctor? I knew her name. And what I ended up doing is I made friends with the director of records. Her name is Patricia. And eventually I kept bugging Patricia, and she walked this form over to another building, got it signed, sent it back in the fax. And it was like a party when it finally came over, because I have his complete application and I got to put the certificate on top. That's a lot. And I don't think there's a lot of people that would do that. I'm going to give a shout out to OHEP. When that critical medical needs application, which is all complete, went in, he had energy assistance within 2 hours. So this is a great bill because it's just people who are 60 and older and they're super sick. So I appreciate your time. Thank you.
Thank you. Are there questions for Ms. Peltier? Okay. And final person seems not to be in the room. So that ends the testimony on this very good bill. Okay, we're going finally to Senator Reedy, Senate Bill 920. And okay, so we will listen to Senator Reedy now, and then we have one witness to testify.
Hi, Madam Chair, Senator Justin Reedy here. Glad to be with you. And the closing bill of the day, we saved the best bill for last. I'll try to be brief as I lay out this issue. Senate Bill 920 would require each county board of health, under the oversight of the county government, to establish clear requirements regarding the manner in which and under what circumstances the health officer or staff may perform inspections and issue citations or cease of operations. The bill wants to establish an oversight board and clear appeal process for businesses who have been given citations and orders to close. Let me talk about why we're introducing this bill. In the pandemic, under the executive orders that came down, obviously done especially early on in an emergency situation where we didn't have a lot of information or knowledge about what we were dealing with, the executive orders put a lot of power into our county health departments. It was understandable in that we have to have, with it being a health pandemic, county health departments had to be able to make a lot of decisions, do a lot of things on the fly. But as the executive orders continued to be changed and amended to allow for more businesses to come back open, and to the whole process became very, very confusing and frustrating for businesses that were attempting, especially small businesses, that were attempting to navigate these different executive orders and what they meant for their business and how to comply with them. And as I maintain, the vast majority of businesses were doing their very best to reopen or stay open safely and do the right thing. But there are times, particularly if it's a small business, where there may be a misunderstanding or there could be an issue where they aren't doing something exactly right. And many times, I know in my district, would have businesses that would all of a sudden be visited, and there'd be sort of a showdown of something they weren't quite doing right, and they could just basically be shut down with very little warning. And there's just a lot of confusion. There was these I don't blame our local health department or any others because in a lot of ways there was a lot of things we were all figuring out on the fly. And they had to interpret a lot of things and how a particular executive order would apply to a particular business where, for retail stores and grocery stores, the rules were maybe relatively pretty straightforward, but sometimes for different other types of small businesses, not quite so easy to understand how some of the rules would need to be followed. So what we want to do is, moving forward, even after the executive orders, after the state of emergency ends, I think what we want to have is a very clear set of guidelines for an appeals process for if a health department, because this was happening before the pandemic, where health departments, there's always disputes, and usually the health officer is pretty reasonable and you can work with them, but sometimes the individual health department staff, or the feeling in the business community, small businesses, is that often there's somebody that's got an axe to grind, and that may not be completely fair to the staff member of the health department, but it would be nice if there was an appeals process beyond just, this is it, you're done. unless you can jump through a bunch of different hoops. So what this bill really just attempts to do is allow for there to be a check and balance. It's particularly important in an environment we're in now, where it's basically the executive orders in state of emergency have given health officers and health departments tremendous power. It's important to have an appeals process set up so that businesses know that if they are at loggerheads, there is something that the county elected officials have set up that allows them to go and have recourse to say, hey, we'd like you to look at this again. And so that's the bill. I understand there's some opposition from some different groups. I know I saw that the Association of County Health Officers reached out to me with their oppositions. One of the things that they mentioned was they're concerned about increasing government bureaucracy, which, I found interesting because that's sort of the complaint we get from our constituents about the health department bureaucracy. So sort of interesting. But in all seriousness, I really would like to work on this issue because I believe if there was a way for there to be an appeals process, it would really build trust in the system. If there were issues where there was an issue of understanding or an issue of competency of understanding what the different businesses were dealing with, having an appeals process might help to smooth things out. And the goal anytime, if a business is repeatedly not following the law, they should be shut down. But the goal ought to be, if a business is out of compliance, whether it's with a health requirement or another type of requirement, that we try to get them into compliance so that there's not a negative impact to the people who work at that business and to the local economy. And so that's part of the goal of this as well. So, Madam Chair, I'll rest with that.
Okay.
It's an important bill and an important issue for us to talk about.
I've been reading your bill as you've been talking. You want this there to be the governing body in each county shall establish an oversight board that includes as a member at least one owner of a business located in the county. It seems like if you do that and you don't have certain other kinds of expertise that are other than the county itself to balance and to know more about what the law is in your county, that you're going to have a big mess right up front, right?
Well, look, I'm open to an amendment that would clarify that there'd only be one. It says just one business owner. Obviously, I'd assume that this appeals board would be more than one or two members. I agree with you. You can't have the fox guarding the hen house. But unfortunately, what tends to happen in disputes that I see and that my constituents bring to me is that a better understanding of what small businesses might be going through with a particular type of requirement or order. Just having that perspective would be helpful in resolving conflicts and disputes. I certainly don't think it should be it shouldn't be more small business owners than necessarily health professionals.
Well, why would you bring in a small business owner at all? I mean, will they have expertise? All of the rules and regulations that the health department needs to enforce. And if they don't, then they're there as sort of a supporter of the business, whether the business is right or wrong.
Well, I would hope that we can trust our county elected officials and elected bodies that they're going to put somebody on there with that with the kind of understanding. Just it's no different than with
I'm not saying it's a bad person, but if I were on there as a business owner, all my business owner friends are going to want me to be sure to take their side and everything. I'm wondering if
how does that relate to
be creating a problem?
Well, Madam Chair, I mean, in fairness, though, in all of our health occupations boards, we have members that are members of the health occupation. Okay. So you can have that argument for most anything.
Okay, I'm going to shut up. Are there any other questions for our sponsor?
Madam Chair.
Yes, Senator Feldman.
Yeah, just real quick, Senator. So, so the bill is kind of a little bit to Chair Kelly's point. The bill's silent as to any qualifications or criteria, beyond the one business member. I guess I was more interested in the fact is what's the standard of review? In other words, normally if you say we're taking an appeal, there's does it have to have been the decision below was, clearly erroneous, or was it arbitrary, or was it seems like you have to have some standard of review. Otherwise, then, you know, the appeal board, the oversight board is really the only one with any power. Like, it almost makes the underlying citation process utterly irrelevant. So it seems, you know, if we're going to do this, you've got to have, I think, some criteria for who can sit there, some relevant background beyond the one business owner, but also, I think, a standard of review for appeal. You know, it can't just be silent. It can't just be whatever, you know, the folks who take the appeal think at that moment on a whim. Anyway, just a kind of a more of a, I don't want to over lawyer it, but that'd just be an option.
Well, the bill discusses establishing.
Okay.
I'm sorry. Yeah, I'm
Go
sorry.
ahead.
Sarah Rita, yeah.
Yeah, the bill discusses establishing a process, but I definitely, you know, we could definitely, it definitely can be more clear about what the scope of appeal is, for sure.
Because if you say it's up to the county, then you could have, again, 24 different counties with different kinds of appeal processes, different standards of review. That would create a little bit of chaos if you're operating in multiple jurisdictions. I mean, there's got to be some uniform standards, I would think. But anyway, Madam Chair, I'll just make this.
Okay, we have one additional witness, Brooke Turton.
Yes, thank you.
Resource Center for Public Health Policy.
Yes, thank you. Good afternoon, Madam Chair. My name is Brooke Torton. I am an attorney at the University of Maryland School of Law, and I work with health officers all throughout the state. I'm here testifying in opposition to the bill because of two fundamental problems. So first, the bill as drafted, it improperly classifies and incorrectly refers to the authority of county health officers and boards of health, and that's going to create significant issues all throughout the Maryland Code. The second point I'd like to make is that this bill purports to create an oversight board, but it does so inadequately. And I just want to focus on that this is not a COVID specific bill, and this has far reaching implications in countless places aside from the restaurant, the bar industry, far outside of that. So first, back to county health officers and county boards of health. County health officers, they do have a dual relationship with the county, but they are state officials. They're appointed by the governor. They report to the Secretary of Health. County boards of health, likewise, they're actually not local entities. They're created by state law, and they're treated very differently than the governing body of each county. So both the health officers and the boards of health, they have very carefully crafted authority all throughout the state in local codes. And so just to highlight a few, even though there are dozens and dozens, things like septic systems, retailer tobacco violations, nursing homes, group homes. So this bill has provisions that interfere with that authority, that relationship between a county entity and the state entity, the boss. So for example, this bill has Board of Health regulations, so that's a state authority that must be approved by the county legislative body, and the oversight board, also a county entity. Also, that oversight board, they make final determinations and they hear appeals when a health officer, the state entity, makes a decision. So this bill actually likely creates conflict and confusion for business owners, for everyone. So depending on the specific type of business or placed employment and or the action taken by a health officer, there's likely to be a provision that already exists somewhere that conflicts with the Board of Health regulation. I just want to add too, that there is an appeal process in place. So if a business doesn't like a decision generally made by a health officer, there's a specific process used. It could be, depending on what it is, it involves the Office of Administrative Hearings, the courts. It's going to differ significantly depending on the nature of the violation. The second brief point I want to make is that this oversight board, the creation of it is inadequate. There's no guidance here. We don't know about terms, membership, compensation, the process for hearing. 3 days is entirely insufficient for this board to hear those appeals. So because of these reasons, I'm opposed, and I urge this committee to issue an unfavorable report.
Okay. Are there any questions for this witness? Okay, then that ends the testimony on this bill. Colleagues on the committee, we will be voting starting at 4:30. If you can be in place at 4:30.